Good morning, everybody. How are we? I see everybody chiming in where they're coming from today. That's really awesome and exciting. I'm so glad you're here. All right. We're going to go ahead and get started. It's 8:30. I know lots of people are still joining. Just going to get something up here quick. I got to get my timer for my Ignite sessions. Hopefully they know that's going on. All right, everybody. So, welcome to day one of the Empowering Change, Advancing Maternal Health Together Symposium. Today, we're turning our focus close to home right here in Iowa, where our work began. Healthy Birthday Inc. was founded in the state by 5 amazingly brave, strong women who turned their grief into action, and Iowa continues to be the foundation for innovation in maternal health. Our mission here at Healthy Birthday is to prevent stillbirths through education, awareness, and action, and has really grown from Iowa's communities, hospitals, and community environment. Today's session highlights the incredible work happening across our state, from maternal health programs and research to partnerships, improving access and outcomes for families in every county. My name is Megan Ockett, and I am the program director here at Healthy Birthday, which again is the nonprofit organization that created the stillbirth evidence-based stillbirth prevention program, Count the Kicks. Again, our mission is simple and powerful: to prevent stillbirths through education, awareness, and action, helping every baby have the best possible start. And we're so excited to have you here. Whether you're joining us from across the country or right here in Iowa, whether you're tuning in from an office, a clinic, a WIC, a home visitor, a healthy start, your home, wherever you're coming from, we're so glad you're here with us today. Over the next 2 days, we'll be hearing from incredible speakers, learning from one another, and sharing innovative work happening across the maternal health space. As we start day one, we celebrate the local leaders, organizations, and advocates driving maternal health forward in Iowa. Your collaboration, creativity, and commitment are what make this work sustainable and what makes a healthy birthday possible for every family. Before we begin, we'd like to take a moment to thank our presenting sponsor, WellPoint, for their generous support. Their commitment to maternal and child health helps make this event possible and reflects our shared vision, ensuring every baby has the best possible start. We also extend our heartfelt gratitude to our many amazing sponsors for their incredible support and commitment to advancing maternal health. Thank you for helping make today's symposium possible. So before we really dive in, I want to quickly cover some housekeeping things. First, technology is great, right? Like, we love technology, but we know technology also can have hiccups. So if we run into any issues today, we appreciate your patience and grace as we work to resolve them as quickly as possible. While today's sessions are just a few hours, I still encourage you to stand, grab a bite, grab some coffee, stretch. We don't have a set break today. And remember, you're all automatically muted and your video is off. This entire day will be recorded. After the event, you'll receive a post-event email from us. Give us 1 to 2 weeks to get that out, and that will have all the information you need regarding how to access the recording, how to access the slides, how to access any of the handouts. So that will be coming in the next 1 to 2 weeks. We also really want to make this virtual experience engaging and fun. Please use the question and answer box there for any questions that you have for the speakers. We will have time for the Ignite session after the Ignite sessions for Q&A, where you can ask any sort of question to any of the speakers. So please use that at any point so we can capture those. And then use the chat for emojis, comments, just that type of interaction to really make this fun and just go along really well to make us feel connected. I'm also lucky to be joined by some of my incredible colleagues who will help ensure the day runs smoothly. And we have Sarah Hybels, who's our program and product administrator, assisting with moderating sessions and answering questions as they arise. Kimberly Iceberg is manning the chat and the Q&A. She will help with any of those questions. And Jen Rowray is our Director of Advocacy Engagement, and she will be talking more about Count the Kicks later on during one of our Ignite sessions. And we also have Nia Thomas joining as well. So while we won't be reading everybody's full bios today, but we do want to take a moment to recognize how incredible each of our speaker is. You can find their full bios and contact information on our website if you'd like to learn more about their amazing work. And Kimberly really wants me to say this. We'd love to see your favorite takeaways on social media. So please use the hashtag healthy birthday as you take photos today or any insight that you glean. One of the biggest questions we get is credits. How do we access the credits? And it's an important question, right? The Des Moines University Medicine and Health Sciences is the accredited continuing education provider. Certificates will be available for download within 6 to 8 weeks of the symposium. And an email will be sent out from Des Moines University when your certificate is available. We would also really appreciate your comments and suggestions for improvement, as this information provided will be utilized in planning future symposiums. The evaluation will remain open through Sunday, November 16th, 2025, and you can access it there through that QR code or that link. I'd also really love to give a huge shout out to the amazing individuals on your screen right now. They helped plan all of the speakers between day 1 and day 2. And so just a huge shout out to everyone for all your time and energy making this the best agenda we have. Here's a list of our disclosures of all of our speakers between the 2 days. There are several slides of these, so you can also view this too when we send out the slide deck as well. So I'm just going to take a moment to go over these so you can see all of those. And lastly, I just want to reiterate again, Des Moines University is the accredited continuing education provider. And again, certificates will be able for download within 6 to 8 weeks of the conference when you get that email from Des Moines University. All right. And with that, thank you so much for being here. Thank you for the work that you do every day. Let's kick off an inspiring and impactful day 1 of the symposium. To officially kick things off, I'd like to introduce Teresa Hersey, Plan President for WellPoint, who will open our program and set the stage for the conversation ahead. Go ahead, Teresa.
Thank you. Good morning and welcome to the Count the Cakes Maternal Health Symposium. It is truly an honor to be here today as we gather to focus on something so critical and transformative, the health of mothers and their babies. I want to extend a warm welcome to all attendees and thank you for your commitment to creating a future where every mother has access to quality health care. As the Plan President for WellPoint, Iowa, I am proud to represent an organization that prioritizes maternal health and actively collaborates with visionary partners to drive solutions. As a premier sponsor of this symposium, we stand alongside you, ready to take the challenges and embrace the opportunities that lie ahead. WellPoint strives to be a bold leader in maternal health, demonstrating an unwavering commitment to ensuring that every expecting mother receives the highest quality care. We offer a variety of programs and services to benefit new and expectant mothers. For example, our Healthy Rewards and value-added benefits. We offer expectant mothers items such as nursing supports, car seats, and cribs. We also offer gift cards for members who complete their prenatal care visits and postpartum care visits. I believe last year we showed a video of our Concierge app that provides personalized support during pregnancy and beyond on a week-by-week basis. Through our long-standing partnership with Count the Kicks, we are proud to support and promote the Count the Kicks app to promote monitoring a baby's movements during the 3rd trimester of pregnancy. Iowa's success has been rooted in a collaborative spirit, and today ignites sessions with a powerful commitment to highlighting some of the wonderful maternal health programs and partners in our communities. I urge you all on this call to take full advantage of this symposium. Engage, learn, share, and be inspired by the pioneering work happening here in Iowa and across the country. Let us all continue to push the boundaries of what's possible in maternal health and equity. Together, we can create a future for every woman, no matter her background or circumstance, has access to the best maternal care possible. We owe it to mothers of Iowa and mothers everywhere. On behalf of WellPoint, Iowa, thank you for being here and please enjoy the symposium.
Thank you so much, Teresa. We really appreciate that. Thank you for your kind words and starting us off strong. So again, we're thrilled to kick off one of the most exciting parts of the symposium, our Ignite sessions. These sessions are all about speed, energy, and inspiration, and we can't wait for you to hear from our amazing lineup of speakers.
Okay, so here's how the Ignite sessions are going to work. Each speaker will have up to 6 minutes to share their ideas. Megan and I will alternate introducing them. And as a reminder, speaker bios are on our website. Please refer to those for additional information on each speaker.
If a speaker has slides, we'll pull those up as they begin so you can follow along. There will be a timer, hopefully, if I can get that going. Otherwise, Sarah and I will come back on the screen when they have 1 minute left in their 6 minutes to do that. Remember, this is fast and fun, so get ready for a whirlwind of innovation, insights, and new perspectives from across the maternal health space in Iowa.
I see you all are already using that Q&A function. So go ahead. Any questions that you have, please put those in the Q&A and we'll try to get those at the end of the session and answer as many questions as possible.
We hope you enjoy this next segment. It's high energy, full of ideas, and always one of the highlights of the symposium.
Okay, so without further ado, let's get started. Our first speaker is Lydia, who is the Executive Director of the Bloom Project. Lydia, take it away.
Good morning. Can you guys hear me? Okay, perfect. Hi, my name is Lydia, and I'm the founder and executive director for the Bloom Project. You could go to the next slide. So the Bloom Project is a nonprofit organization that I created for the Quad City area, so Scott County and Rock Island County in Illinois. And we provide postpartum care packages for BIPOC birthing women and their families for the postpartum period. And so we came up with this in late fall of 2023 and then became a 501c3 in 2024. This mirrors a program that already goes on in Chicago called the Love Package Project, which does the same thing and has additional services. Next slide. So our mission is to empower and uplift BIPOC families during the final stages of pregnancy and postpartum period. Through education, awareness, love, and culturally responsive support, we strive to improve health outcomes and positively impact the lives of birthing families in our community. Our vision is to see women bloom into the people they want to be. And then our motto is helping mamas bloom. Next slide. So this is my amazing team. This is our board. They come from all over. They've been very supportive. My husband is a part of the team, my sister and some friends. We have a few moms who live in the Quad Cities area, and they help put together our care packages, deliver them, and all of that, and help organize the organization. Next slide. So we know that there are disparities in maternal health, especially when it comes to BIPOC populations. And so I'm just going to read a couple. Black women are less likely to access paid leave through their jobs than white women, adding to their risk for their risk of the worst maternal health outcomes. And then Black and Indigenous women face 2 to 3 times higher rates of maternal mental health conditions, and women of color are more likely to have hypertensive disorders during pregnancy. And so those are some of the reasons why we do what we do. We want to help BIPOC populations during that last trimester postpartum period. Next slide. Okay, so what's inside our care packages? We do have postpartum care supplies. We also put in cleaning and household supplies, nutritious snacks, hygiene items, self-care items, diapers and wipes for baby, a gift card to get groceries or anything that they need during that postpartum period. We also provide an encouraging note, and we give them a folder of national and local mental health resources. And then how can this help? It can provide comfort and encouragement, establish a line of support, ease costs for new families, promote self-care, connects family to resources, and of course, it builds trust. Next slide. So from September 2024 to October 2025, we have given away 50 postpartum care packages, and we have received $10,000 in grants and grant funding for operational and program costs. And so we've noticed that this has helped. I've included some comments from some of the people who have received some packages. And mind you, these packages, they're big. Like it's like a big bag. So they get a ton of stuff, and we're looking at maybe like $100 to $150 per bag. But one of the comments says, I was surprised and felt loved, like there were people out there that wanted to take away the burden of having to gather those things myself and who understood. And then the other comment says, I did not have to think about what I needed for the delivery and postpartum. And some things I wasn't sure I needed, but
Oh, Lydia.
being useful. So
Yeah. Lydia.
that it is helping people during the postpartum period. Go to the next slide.
Okay, sorry.
Hello?
You cut. Yep.
Oh,
Can
that's
you
not
hear
good.
us? Can you hear us okay?
That's crazy. Hello?
Hi, can you hear
Yes.
us?
Yes, I can hear you.
Okay, you cut out just a
Yeah.
little
Can you
bit
hear me?
there. Yeah.
Ooh,
Yep.
okay.
Yep.
Okay. So yeah, I was just explaining the comments from the slide if you didn't hear that, but you can see that from reading from the comments that this has helped some of our ladies who received a postpartum care package. Can you go to the next slide, please?
Yeah.
Okay. And so this is how you get a postpartum care package, be a BIPOC mama or birthing person, up to 1 year be up to 1 year postpartum, live in the Quad Cities, so Scott County, Rock Island County. We do have a Google form that is available on our website, which is under construction right now. And on our face
Oh,
page. And then once you email, and then we will and the BCA, and then one of our local community centers. So there's a YWCA in Rock Island and in Davenport, and our community center. And so in the future, we just look forward to just being able to continue providing these postpartum care packages. We would like to do more care packages, so maybe 100, 150 a year, and then possibly provide other services. And so you could go to the next slide. And so on the next slide is our contact information. If you know of a family who lives in the Quad City area that you think would, benefit from a care package, please let us know and we will connect with them. And then on the next slide, if anybody willing to donate, you go ahead.
thanks.
But this is our on this information to anybody, please do so. And so yeah, that is all that I have about the Bloom Project.
Thank you so much, Lydia. Sorry about the technical difficulties. Feel free to put some of that stuff in the chat for the contact information, because I think you cut out there too. So thank you. And now we'll move right along. This is how it works. So Lily is up next with Breathe Physical Therapy and Wellness. Lily, take it away.
All right. I'm Lily. I'm one of the physical therapists at Breathe, and we have two clinics. We have one in West Des Moines, and we have one in North Liberty, and I am in North Liberty, which is in like the Iowa City, Cedar Rapids area. All right, next slide. So my goal for today is that everyone listening leaves knowing what pelvic floor physical therapy is. So I think that's right now like one of our biggest barriers to access to care, is just that people don't know that this kind of physical therapy exists, and people don't know that most people's insurance covers this kind of care, and that in the state of Iowa, physical therapy is what we call direct access, which means that you do not need a referral from your doctor to go to physical therapy. You can just call the clinic and start. So regular physical therapy, there's a few common misconceptions. And I think with any kind of physical therapy, people think that you need to have an injury or be post-surgical. So a lot of times you can come to physical therapy for a problem that has been going on for a long, long time with maybe no injury or some type of chronic pain. And I would say the same applies to pelvic floor physical therapy. So first of all, like, what is the pelvic floor? So this image is just the front of the pelvis. And so if we could see down in, what you would see is that there's a bowl-shaped set of muscles at the bottom of the pelvis, and that is the pelvic floor. They're small but mighty, and they do a lot of work to help support our body. So a common misconception about pelvic floor PT is that it is just Kegels, when really it is so much more than that. It's core strengthening, it's glute strengthening, it's hip mobility. Sometimes it's learning how to relax those muscles because they're too tense. And it's very specific to each individual. So in our clinic, it's all private treatment rooms. So there's not some big gym. We have single person rooms where you're one-on-one with your physical therapist and getting a treatment that's really specific to what you want to accomplish. Next slide. So what can pelvic floor PT help with? It's a huge spectrum. So tons in pregnancy. So in pregnancy, it might be low back pain, hip pain at night with sleeping, like that tossing and turning and pain in the outer hips, calf cramps. It could be urinary leaking. Maybe it's lingering core weakness from a previous pregnancy that someone wants to work on. Maybe it's birth prep and wanting to just like have healthy exercise programs throughout pregnancy, know what kind of exercise is pregnancy appropriate, or know if like their current exercise is okay. And sometimes it's preparing for that delivery itself, maybe learning how to push and coordinate the pelvic floor muscles so that pushing is effective. Other things outside of pregnancy that pelvic floor PT can help with is pain with intercourse, urinary leaking, prolapse, which can feel like kind of just like a vaginal heaviness, C-section recovery, diastasis recti recovery, which is an abdominal separation that can happen after having a baby. It's very common. Difficulty with bowel movements, and then urinary frequency and urgency. Next slide. When to go to pelvic floor PT is a really common question. So a lot of people are starting to learn that after having the baby, around the 6-week point is a great time to go to physical therapy. And so that is absolutely correct. Going postpartum is a great time. We see people before the 6-week period because it's not heavily exercise based in that like 2 to 6 week period. It might be more, here's how to stretch and open your chest after long periods of time of holding the baby, or stretches for relief of neck and shoulder pain after nursing, all sorts of stuff. But the right time to come, you can come during pregnancy, as early as you want in pregnancy to start learning and preparing good stretches to do throughout the week. Anytime postpartum. So if you're recovering from delivery and you have lingering urinary leaking, core weakness, anything, postpartum is forever. So even if it's 10 years, 20 years, anytime later, postpartum is forever. It's never too late to get started on feeling better. A lot of times people come in when they're having new symptoms in perimenopause. Great time to work on stuff. And honestly, just whenever you are ready. So there can be pelvic floor problems outside of pregnancy, like before you even get pregnant and have a baby. So sometimes people, newly married, start having intercourse for the first time, pain with intercourse. We can help with that. Not able to use tampons. High school athletes that are having leaking in their sport. So lots of things there. And then I did just want to answer one question since I won't be on at the end. Someone asked if does pelvic floor PT have anything to do with frequent UTIs or bladder infections? And there's kind of two sides of that coin. One is that tight pelvic floor muscles can make it harder to empty your bladder, and also tension and pain in the pelvic floor muscles can mimic the symptoms of frequent UTIs. So especially if someone has UTI symptoms but with a negative UTI culture. Okay. And so lastly here, how to find a pelvic floor PT. So in Des Moines, we have our clinic in West Des Moines, and then a clinic in North Liberty area, which is Iowa City, Cedar Rapids. But there's a lot of other private clinics or clinics owned by hospitals that have a pelvic floor specialist. So trying to find a pelvic floor specialist, you can ask your doctor if they know any resources. And there's also some online directories of pelvic floor PTs. And telehealth is also a great option. So there's a little bit of like lack of access in rural areas for pelvic floor care, but pelvic floor PTs do provide telehealth. So that's a great way to access a provider if you live like hours from the nearest pelvic floor provider. All right, next slide. And then lastly, just share this with a friend. That is my kind of goal for everyone listening today. Is that's how we spread the word about this kind of care. If you can just tell one person, maybe someone who is pregnant or just had a baby, like, hey, like if you're dealing with any of these issues, there's help for that. It doesn't have to be, you know, the most terrible symptoms to get relief. You can get relief on any part of the spectrum.
Thanks, Lily. We appreciate you being here. So great to see you, friend. And next, I would like to introduce Christine with Broadlawns Medical Center. Christine, take it away.
Okay, hi. I'm going to make this really fast and furious because I have to cover a lot of things about perinatal mood disorders in a short period of time. So I'm not going to read a lot of the slides. So go ahead and go to the next one. Basically, my goal is to talk a little bit about perinatal mood disorders. I am a perinatal mental health therapist at Broadlawns. I've been working with moms for over 10 years. And just talk about the frequency. Like this happens to anybody. This can happen to anybody from any place. 1 in 5 women, 1 in 10 men can experience depression or anxiety. Next slide. And what is it? The who? It can be, you know, fathers, caregivers, and children. Those are the people that are affected by perinatal mood disorders. It affects the entire family. Next slide. Okay, this is a really quick little chart here that kind of talks about the breakdown of what we're talking about when we're talking about baby blues versus an actual disorder. So like within the first 2 weeks, a lot of people associate that baby blues, up to 80% of women can experience mood disturbance with that hormone dip when you have baby. And that could resolve between 3 to 4 weeks after baby is born. And then we kind of have this period of time where we assess for other symptoms. Next slide. Okay, so this is a very vulnerable time in a woman's life, as we all know, because we're all here caring about moms and families. There's an increased risk of suicide during the first 12 months postpartum. So after giving birth, we have this opportunity to intervene to help moms. And with any mood disorder, there's symptoms that affect people outside of just the person. It's also the infant, the caregivers, the family. And I just want to talk a little bit about that and how much this is such a vulnerable and very delicate population. Next slide. So I kind of went through PMADs really quickly. I know that not everyone knows that. When we're talking about perinatal, I'm talking about the span of conception up to 12 months postpartum. And I like to say up to 2 years postpartum, but that's anecdotal. It can be depression, bipolar disorder, psychosis. It can include, generalized anxiety disorder or OCD. Next slide. These are the physical symptoms of some postpartum depression. I like to put that out because physically our body responds. And then you can go to the next slide for the more emotional symptoms. Just kind of look over through the, sometimes having thoughts of hurting your baby is really associated with OCD rather than actually depression. So just putting that out there. Next slide. Okay, what puts moms at risk for developing these symptoms? So some moms just have a genetic predisposition. So that's really speaking to my bipolar disorder folks. And just to point out that some moms experience their first manic episode in the postpartum period. So this is a time that is once again very delicate. There's women that are just highly sensitive to hormonal changes, so that puts them at risk. Psychological factors, their upbringing, what are their goals? If they're highly motivated, highly educated, highly you know, expectations of self can be really high. That actually puts them at higher risk. Family history, of course, and then inadequate support, interpersonal violence, so like domestic violence situations, stress and poverty, and also military families, teen families, and mother of multiples. Next slide. Things to also consider in this population is just, how to look at all the different factors that also are going to kick the dirt up for these moms. Hormonal triggers, rapid weaning, returning to work, illnesses, grief and loss. That's another one. Did they lose someone right before they gave birth? Do they have any, have they had a panel for their thyroid? Do they suffer from anemia? Do they need low iron? Did they lose a lot of blood? Did they have a hemorrhage during their birth? And have they been checked for iron? So just some things to think about. Next slide. Okay, the impact on baby, right? So once again, I don't see mom as just this isolated person. She is the center of lots of different things. And so we talk about the impact on attachment. If mom has untreated depression or untreated anxiety, and there's the lovely little quote there that you can read, and just talking about this crucial period of time in which we have insight. We have some idea that this is going to happen before she even gives birth. Next slide. So what are we doing? Many of you probably already know all this stuff, but I just put it out there. We're doing the Edinburgh, the DMPS screening. A positive score is 10 or higher. However, it's not the best screen in the world. So we need more resources. Oh, I knew I didn't have a lot of time. Okay, next slide. I'll just skip that stuff. Okay, here's what I want to get you walk away from, all right? A lot of times we're not intervening in a way that is a helpful manner. So we're not looking at women in the pregnancy to be able to prepare them well for postpartum. Next slide, and I'll tell you a little bit more what we need. What we need is services that are more inclusive of mom and baby. Iowa doesn't have any. We don't have any intensive outpatient programs for moms and babies. When mom has a mental health crisis, she's separated from baby and she's going to go seek out services. Well, that is a barrier. That really hurts her ability to really seek out that care. And also, if we're not seeking care until the problem is there, we also have a kind of a big step we have to get over. For moms to see a therapist like me, they have to feel comfortable. And if they've never sought out mental health services, this can feel really odd and very dysregulating for them to even seek out services. So we need to reduce the stigma for mental health and get these moms connected. And I will stop talking, Megan. I'm sorry.
You're
Oh,
fine. Yeah, do the call to action. Let's do it. What
okay.
can we do? Do it.
It's just a little bit of integrated services that would help having mental health professionals integrated into OB centers. That would be the best course of action to go forward for Iowa. Having just a little bit of plug for our midwives are certified in perinatal mood disorders as well as Dr. Bailey Brooks is also a perinatal specialist at Broadlawns. So we're doing our best to try to do what we can in Iowa. So this was helpful, and let me know if you have questions.
Thanks. And we will again have time for questions at the end of the Ignite sessions before we close. So feel free to keep putting those questions in the Q&A and we'll definitely have time for that. Next, I'd like to introduce Ashley and Michael with the Community Crate Project and Uplift. So I'm going to toss it over to them.
All right, awesome. Good morning, everyone. Thank you so much for having us today. My name is Michael Berger. I'm a project coordinator for Uplift, the Central Iowa Basic Income Pilot. Together with my colleague Ashley, we make up the project coordination team for this project. Next slide, please. First, I'd like to just give a quick shout out to the diverse 11-member funding group that made Uplift possible. As you can see, this project has cross-sector collaboration between public, private, philanthropic, and nonprofit sectors, which is something that's pretty unique about this project. Next slide, please. But if this is your first time hearing about Uplift, we are a community-wide learning opportunity studying the impacts of a basic income on the lives of low-income individuals in our entire community. Through this study, we are investigating how individuals and families' lives are changed when stressors associated with poverty are reduced. Of those participating and receiving monthly payments, 85% are women, mothers, and even grandmothers. But in addition to the study, we have partnered with numerous community-based organizations to host community conversations on various basic needs topics and subjects. That includes housing, employment, navigating public assistance programs, benefits cliffs, and what the broader experience of poverty looks like for our neighbors and community members. Next slide, please. Now, as a result of these community conversations, the idea to build the community crate was born. While the research is foundational, we know that data alone is not enough to inform policy and change. So that's why we worked with local housing experts and advocates here in Central Iowa to create the Community Crate Making Central Iowa Home exhibit. This is a museum-style exhibit that brings to light the struggles that many Central Iowans face when trying to access quality, safe, stable, and affordable housing. Next slide, please. And kind of like how I mentioned, the Community Crate was created through community input and collaboration. So I want to give a huge shout out to all the organizations that helped us craft the story of the Community Crate and shared their latest research and data for us to include within it. We also worked with local vendors, Project 7 Designs, and Honey's Custom Home Services that helped us build the crate and design the exhibit. So this truly was a community effort, and we wouldn't have been able to do this together without our partners. Next slide, please.
Awesome. So within this exhibit, you're going to find information on housing related topics such as the effects of redlining in Central Iowa, the trends we see in eviction rates, the availability and affordability of housing, home ownership initiatives, and potential housing solutions. To date, we've had over 700 individuals visit the crate since our launch in July of 2025. Next slide, please. And so this is where we really see the connection today. Inside the crate, one of the most important topics covered is eviction. Since the pandemic, Iowa's eviction hearings have surged, reaching almost 22,000 filings in 2023. That's up from 2020, where we saw about 12,000, almost 12,500 filings. This is when we had the eviction moratorium and emergency rental assistance really helping to keep our families housed during a public health emergency. Here in Iowa, we see about 51% of eviction filings get dismissed and they never go to court. Yet that eviction filing remains on a public record forever. One of the solutions highlighted in the crate is eviction expungement. This is a concept that comes from our partners at Homeward, who champion Iowa adopting an eviction expungement process with our state legislature every year. The connection between eviction threat and birth outcomes is becoming well documented. On the screen here, you'll see there's a 2021 Eviction Lab brief that finds that infants born to mothers who have an eviction filed against them during their pregnancy are more likely to be born prematurely or at a low birth weight. They also have higher mortality compared to infants born to mothers evicted at times other than when pregnant. Even children born to the same biological mother and experience an eviction in utero, those children have lower birth weights on average than their siblings who didn't have this experience. So this research is really pointing to making it unlikely that there's other indicators that are worsening these health outcomes. We also see that this disproportionately impacts our communities of color. We see people of color in Iowa making up about 17.7% of Iowa's population, but 41.1% of tenants facing eviction are folks of color. Researchers Seeley and Jefferson and colleagues published an April 2025 article that found that Black women's preterm birth risk was strongly associated with increasing neighborhood eviction filing rates. Birthing people who lived in neighborhoods with higher eviction threat during pregnancy compared to before their pregnancy had a 68% higher risk of preterm birth compared to those who lived in neighborhoods with persistent low eviction threats. So Michael and I see the community crate as one educational tool to help spark conversations around solutions and interventions to really address this issue of eviction threat and the stress that comes with that. Next slide, please. So our call to action today is to get involved and to learn more about eviction and policies that can help reduce the negative impacts associated with it. Homeward is the Polk County local continuum of care organization. They have great resources available and more information about eviction expungement. The National Low Income Housing Coalition is a great resource for both national and statewide data. And of course, Iowa Legal Aid, whether that's brushing up on eviction data or getting involved in their eviction help desks. And finally, bring the crate to your community. Let's spark some conversations. You can sign up for Uplift's newsletter at upliftiowa.org to learn more about the study's final findings that will come out this summer 2026. Find out where our next community conversation is and bring your voice and keep up with where the crate is. And here's our contact information, and thanks for having us today.
Thank you, Ashley and Michael. Really interesting information, and thank you for sparking conversation and for your call to action. So next, I'd like to introduce Lil from EMBARC. Take it away.
Hey, thank you, Sarah. As you can see on the screen, I don't know if you can see me or not. I can't see myself, but my name is Muani, and I am from EMBARC, Ethnic Minority of Burma Advocacy and Resource Center. And our organization was founded in 2012, and we have our 501c3 in 2013. And I want to mention about our models is train the trainer models, and our missions is always educations, advocacies, and community development. Next slide, please. And as you can see on the screen, this is our community leaders who come across, to coordinate our organizations. Next slide, please. And this is where the Burma is from. In order for me to talk about our organizations and programs and the services we provide, I have to mention about where we come from and our culture a little bit. So this is where it's located. As you can see on the red circle, this is where Burma is located. And it is, the biggest country in Southeast Asia that was bound, the border is China country, Bangladesh, and India and Laos. Next slide, please. Next, please. Yes, as you can see, this is the resettlement process, and I won't talk about this a little. I would like to skip this because I have a lot of other program to cover. Thank you. And as you can see the screen, we put on 5 program, but actually we have 6 program mainly, and our 2 main core program is Early Childhood Parent Navigator program, which I am leading, and the next thing is Crisis and Advocacy, community-based education. All of this program we run those program mostly based on volunteer. We also call under the essential needs, we have Access Center, which we provide wraparound services on each Wednesday. So we really looking for volunteers. So most of these programs runs by volunteer base. Next slide, please. And as you can see, our goal is to empower community parents with confidence and deeper understanding of the developmental and parenting norm, helping them raise successfully youth in their kids' childhood. Next slide. And in order for me to mention that, I want to talk about our program. As we can see, Burma Focus. So all of our program, it's based on Burma Focus. And I want to talk about how we meet. This is, we serve a pregnancy mom to someone who have under 5 and younger kids. And we call Parent Navigator, those Parent Navigator, and I want to say one more thing. So in Burma, there's the diversity is, a lot, and we speak over 150 different languages. So I speak myself is Chin, and I can speak Burmese, but there's other 148 languages that I don't know how to speak. So in order for me to reach all of the Burma populations, I have to have a parent navigator from different community. So I have 8 parent navigator from different community right now. No, sorry, 10. And those we meet each week and we provide training, and those parent navigator will go out to their community and share with whatever things that they learn from our organizations. And one, I want to highlight about 3 things. The first thing I want to highlight is learning circle. We call it learning circle. That's when we teach a parenting norm. We all know that there is no right or wrong for parenting, but basically on the parenting in our country was usually very, we find that harsh or difficult compared to this US parenting norm. So our parents are parenting the way that they were parented by their parents. So it's really difficult. However, parenting in our community, trying to adopt this new parenting style, can be a challenge in, a parent's life too. So which is why we offer a learning circle, and through this program, we provide a Your Journey Together training that was developed by DeVro Foundations, which help resilience in the children by emphasizing and protective factors like that build a strong relationship, initiative, and self-regulations. And it also educates parents to know the importance of self-care in order for them to be able to take care of their child's social, emotional, and mental health well-being. And another thing we provide is called Parenting the Love and Logic Way. So that provide parenting, the knowledge of how to avoid argument with your children to show their kids empathy and love in order for them, to support in their daily life. So those are the training that we give through, and we started like supporting a pregnancy mom so that they started knowing all this pregnancy, all this parenting before even their child was born. So this is one way of our supporting to pregnancy moms and a parent. Another thing I want to highlight is we call it co-parenting children in the middle class. And going through divorce is very difficult for parents. On top of that, our community has to go through children in the middle class, which they can get in a lot of locations, for example, like DMEG or other organization. But however, all this registration fee and language barriers often prevent our parents from understanding the class and the content of that class. That's helping their anxiety. So we have a court-approved trainer to address all those challenges, and we give a free training for those classes. Next slide, please. Next. Yes, thank you. Another thing I want to highlight is, first of preschool support. You might say that why this is a big of a highlight for this EMBARC program, but I want to say that in our program, our community, our kids, usually moms, 85% of mom are stay-home mom with their kids, and usually the kids are with mom all the time. And once they are turning into 3 years or 4 years, and they start getting into the preschool, and this is their first time being apart from their parents, not knowing, and they do understand some English back in watching the TV, all this literacy movie or in English, but they do understand some English. But this is the reality. This is the first time they are being apart from their parents, looking into the teachers that doesn't speak their own language. It give them a lot of anxiety. And for the parents, this is their first time aparting from their children's, and they have a very big language challenges and all that stuff. So we provide this first support. And by our community parents seeing us being there, as in then we can be acting as their voice. And also for the children's part, once they see us, they someone who have the same color skin or the same background that help them better in regulating in the classroom. So this is how our program do. And lastly, my call to action is, as I mentioned earlier, all of our program are running on, based on the volunteers. So we are always looking into the volunteer opportunity. And also we are also looking into the new resources all the time, since I myself is not born and raised here. So I myself needed a lot of resources and support. So those are our call to action. And this is our contact information. And thank you so much for having me here.
Thank you so much for that. EMBARC holds a special place in my heart. I've worked with them for several years with Healthy Birthday, and we worked together to put up billboards across central Iowa in Burmese. So that was really exciting. They helped translate our app into Burmese. So thank you so much for that information. Really, really appreciate it. As a reminder, continue to put questions in the Q&A. They can be questions for the entire group. So any kind of comprehensive type question or for a specific presenter as well. So before we move on to the next speaker with Becky, I'd love to share a few words from Melina.
Hello, I'm Jennifer Vermeer, the Plan President for Molina Healthcare of Iowa. Molina Healthcare is very proud to sponsor this year's Empowering Change, Advancing Maternal Health Together Symposium with Healthy Birthday. Molina's maternal health programming addresses the needs of pregnant members with value-added benefits, doula coverage, care management, health education, and community building. All of these initiatives support and encourage comprehensive perinatal support of both healthcare and SDOH needs for our members. We are so grateful for the opportunity to introduce Becky Borgman of EveryStep. When EveryStep saw a need in our community to make healthcare more accessible outside of the traditional healthcare setting where individuals are already receiving supportive services, we knew that this was an innovative model that we wanted to support through our Molina Cares Foundation. We now turn it over to Becky to share more about how we've collaborated to advance maternal health together. Welcome, Becky.
All right, Becky, that's your cue.
Thank you. Hi, I am Becky Borgman. I am the Maternal and Reproductive Health Director here at EveryStep. Next slide. At EveryStep, our mission is to empower individuals, support families, and strengthen communities. Next slide. Who is EveryStep? EveryStep is a nonprofit organization that provides healthcare and community services since 1908 to care for people and connect them to support at every step of their health journey, from preconception all the way through hospice. Our care and support services serve more than or provide more than 20 different programs that are grant funded to support mothers, children, families, or immigrants and refugees. Our maternal, child, and reproductive health services include maternal health, child health services, family planning, nurse-family partnership, 9 to Thrive, and the EveryStep Doula program. One thing I really appreciate about EveryStep and working here is we really do adapt our programs and our services to adapt to the needs of what the clients want and what the communities are asking for. We can provide anything from one nurse home visit postpartum, because who doesn't want someone to tell them what is happening postpartum when they come home with their baby, to a nurse coming into a home for over 3 years, to someone who doesn't really want someone coming into their home and provide services over the phone. So we will adjust our services to fit the needs of the client as they know what will work best for their life. Next slide. We provide services currently in Dallas, Polk, Madison, and Warren. So we do have a mixture of urban and rural communities. Next slide. Since in 2023, 41% of births were reimbursed by Medicaid. That is 14,000 of the 34,000 births in Iowa. Additionally, 1 in 16 women of childbearing age are uninsured. That is a large population of our community that is uninsured and underinsured. Women with Medicaid experience higher rates of maternal morbidity and mortality, with significant disparities by race and ethnicity. This has increased over 25% since 2017, which is trending in an undesirable direction. Iowa ranked a D+ for preterm birth, and all races outside of white and Asian are not obtaining early and adequate prenatal health care. So we have needs in the maternal health world that are not being met, and how we are currently practicing is not working. Next slide. Iowa's existing trends in maternal health outcomes are being compounded by the increasing number of hospital closures of their OB units. Since 2000, over 40% of 40 hospitals in Iowa across the state have shut down their OB units. This means longer travel time for just routine prenatal care and longer travel time for that emergency care, where every minute does matter in those scenarios. These closures are greater compounded by this or create greater strain on the hospitals that are still existing, that already are experiencing staffing shortages. Additionally, in a recent Polk County Health Needs Assessment, access to care was one of the top concerns in Polk County. EveryStep's response to this was, I wanted to increase access to care while providing a variety of services. I wanted to push a public health nurse to the full extent of her licensure, which includes providing maternal health, that nursing health assessment, oral health education, screening for mood disorders, because as we spoke earlier, that is something we really need to focus on. I wanted to be able to provide birth control and STI testing and treatment on spot, and help assess children for any developmental needs or lead screenings at the location of the client's choice, where they're already located. Next slide, please. So this service model was made possible because of Molina, so thank you for that beautiful introduction. Molina Healthcare is Iowa's newest managed care organization that provides Medicaid programs. Molina has a commitment to building stronger communities through improving people's health and lives, and they provide investment into solving that gap that exists to access to care and delivery of healthcare today. And there is your suitcase clinic. So they support local nonprofits like EveryStep in focusing on improving social, economic, and environmental needs. And over the past 2 years, Molina has helped support us with over $175,000 to implement these services. Next slide. So the key element to be able to provide these services is linkages to community partners and doing a continual environmental scan on where are these services being provided, are they being utilized, and where are services still needed, and where are those gaps. So currently, we are providing these services at Wick in Polk, Dallas, Madison, and Warren counties, Oak Ridge, Monsoon, the Beacon, Dallas County Health Department, and House of Mercy. And we are continuing to look for places that need these services. So if you know someone in Polk County or Polk, Dallas, Madison, Warren that are in need of a nurse coming and providing anything from maternal health to family planning and child health, we would be happy to come and provide those services. That would be my call to action. We can leave questions for the end.
Thank you, Becky. We really appreciate you being here and for taking the time to tell us more about EveryStep. Next, I'd like to introduce Bethany with Gunderson Health. Bethany, you're up.
Good morning. So I don't know, my camera is not working now all of a sudden, of course. There we go. Yeah, so I am super happy to be here with you guys again this year. So I'm Gunderson Health. We're now changing names to Amplify. So I'm the RN IBCLC. We are a critical access rural health facility. So following Becky speaking is absolutely perfect because we are in these maternal healthcare deserts, right? So we deliver around 100 deliveries yearly. My numbers for this last year were actually over 100, but I have a large population of shared care. So, that being said, stuff we saw years ago, very rarely we see almost on a regular basis now with our obstetrics. So I have a huge variety in my patient population, ranging from non-English speaking to low socioeconomic, huge transportation issues, long travel times. Our big goals have always been, how do we care for our patient population safely, conveniently? How do we also give them a good experience? And how do we grow our department and keep our doors open and keep up with evidence-based care and new equipment? right? Because we're doing all the things. All of us here are wearing multiple hats, and we're participating in AIM, and we're involved with, all the breastfeeding things. But it gets tough. So we were really lucky to have Ashley Hanson, who's the representative for our state, come and tour our facility. So we had an application for federal funding to really help maintain rural maternal health care. And she came through, she sat down with us. We got to show her the department. We got to actually sit and talk about, what challenges our patients have, and then what challenges we have in caring for them, and how we've really attempted to tailor our care for them, and just change how we practice overall. So we were really, really blessed. It was super exciting that we were able to secure $1.1 million in federal funding with her help. And then we will have an additional 370,000 that will come from our capital budget. And then we have a local Palmer Memorial Foundation. So they are going to chip in $350,000 to the project as well. So that's huge, because that's just our local community, and like our employees here and stuff, just saying this is important, this is vital. So what this does to a rural facility like us is, we can over time make these things, or over time we can purchase new equipment, but this is going to allow us to do it all in one big movement. So that's just amazing. So what we'll work on renovating will be to improve workflows, improve our room sizes so that they're all up to code, and increase that usability. We'll refresh areas. We'll have a designated triage / antenatal testing rooms. We already have designated lactation area where I see outpatients. We also have a milk depot, and we are also a milk dispensary. We work really close with Jean Drulis and her amazing team there at the Mother's Milk Bank of Iowa. And we also provide bereavement services, and then have community support paired with that too. So with our rooms being up to code with square footage and just being more equal, this means a lot too to rural maternal health, because then your longevity of your department is better as well. Like if any of you have worked obstetrics, you have your favorite rooms, right? For labor, delivery, postpartum, that kind of thing. And we have 4 LDRPs. So now they will all be equal. They'll all be, pretty much the same as in care. So that's going to allow us to have patients in those rooms, and just make sure we don't have rooms getting hit hard with every delivery. Another big issue of importance for us in this rural maternal area is it warm and family friendly? We didn't want people to come in and have like a sterile, cold environment. We want spouses, children, significant others, grandparents. We want everybody to come in and be comfortable and really feel like home. And with serving a huge multicultural area with, different practices and beliefs, we also want them to come in and really maintain, their day-to-day living or their day-to-day practices. And I have a lot of moms that come to me expecting, and they're like, we've never delivered in a hospital. They've always had home deliveries in, Nicaragua or Guatemala, or, or this is their first baby in the United States. We've had some refugees, and stuff. And so how we practice obstetric care is very different to what they have experienced in the past. So we want them to come in and just be really comfortable and like we said, safe and good experience. So a majority of our patients already have quite a driving distance to get to us for care. It's not a stretch to say an hour or more sometimes. So they're also coordinating travel. And so it's really important for them and our communities to maintain rural care. So even if I have patients that cannot technically deliver here because, maybe they had some pre-existing conditions, or perhaps things have now popped up during the pregnancy that they need to be seen elsewhere with maternal fetal med. We that mom still needs us here, and she still needs our doors open, and she still needs us to be up, practicing current evidence-based. And so that way that she has a safe pregnancy, and, and her baby's well taken care of, and they're both receiving the best care they possibly can without that constant travel piece, or the additional economic hardships and stress. I think, I don't know how many times I've said it now. So it's like that call to action, really, maintaining rural maternal care is vital. When you lose that piece, you also lose, family care. Some of these hospitals that have had closures of OB have then lost their surgical departments. If families can't come in and have everybody be seen or everybody be cared for, then a lot of times they're going to seek out other facilities, which is going to cause them to be traveling further, for that care. So then you're just adding to their already, issues. So a huge thank you goes out to Ashley Hanson and her team, and her passion really for making this a priority in our state. We are really excited to be able to hopefully, hopefully next year, Megan, you'll have me back and I can show pictures and of our new department and our renovations. And then, of course, all the positive outcomes that come from just keeping our OB department here, and keep going with all of that.
Awesome. Thank you so much, Bethany. Yes, always happy to have you. I'm sure there'll be questions in the chat for you. So stick around and we'll be sure to get to those at the end. Thank you.
Yep.
All right. I may be a little biased for this next speaker, but I'm excited to introduce Jen Rowray, our Director of Advocacy and Engagement, to give you more information about Count the Kicks. Jen, take it away.
Thanks, Megan. And I'm excited for all of you to hear more about Count the Kicks. Hopefully, many of you know about us already, but please don't tune out if you do, because we have new initiatives and new ways for you to engage with those that you serve. So I am excited to share more about the evidence-based stillbirth prevention program, Count the Kicks, which has saved lives in 38 states and 8 countries that we are aware of. And we know there are so many we'll never hear, including sweet Mabel. Look at that smile. Mabel's mom, Megan, used the Count the Kicks app and shares that the only red flag that there was a problem in her pregnancy was was her daughter's change in movement. As as this testimony indicates, we can see that Count the Kicks empowers expectant mothers by educating them about a crucial, often overlooked sign: a change in fetal movement. This change can be one of the earliest and sometimes only warning sign that something is wrong in a pregnancy. By providing simple, accessible tools to track fetal movement, we give moms the confidence to speak up and take action when it matters most. Here is how you can educate expectant parents on how to pay attention to their baby's movement in the 3rd trimester. We want expectant parents to monitor their baby's movement every day, preferably at the same time each day, beginning at 26 weeks if high risk and 28 weeks for all other pregnancies. Parents should pick a time when they know their baby's normally active and time how long it takes their baby to get to 10 movements, and also note the strength of movement. Every baby is different. For example, it may take my baby 5 minutes to get to 10 movements and your baby 30 minutes. After a few days of counting, expectant parents will begin to see that average length of time it takes their baby to reach 10 movements. This is their baby's normal, their baseline. Movements are a roll, a kick, a poke, a jab, a push, anything except for hiccups, which are considered involuntary movements. If a parent notices a change in their baby's normal, their baseline, they should contact their provider right away. Next slide. So we have a Hallmark tool known as the free Count the Kicks app, available in 20+ languages, both on Apple and Android products. We encourage users to register so that they can continue to get all their data history. When a mom sits down each day to focus on baby, to bond with baby, and feel those first movements, they hit that big teal foot you see on the slide that's running. So you can kind of watch what the app is doing in real time. So once they start, a timer starts, and they tap that footprint every time they feel baby move. A push, a kick, and after they get 10 movements, the timer stops and the app asks the user to rate the strength of their movements, because research shows that not only should we be paying attention to how long it takes baby to move, but the strength of those movements as well. Once they rate the strength of movements in the app shows a graph, a visual representation of how baby has been moving. It is that trend line of how long it takes their baby to get to 10 movements. Think of it as a data download of mom's intuition. They can download that data and share it with their provider or others. Other features include the ability to count for single babies or twins, daily reminders, and so much more, including a free resource where the app user can access a national database, find help, and enter their zip code and find free or low-cost resources near them, such as food banks and child care assistance. Another important resource is a direct link within the app to HRSA's maternal mental health hotline. Finally, the app includes a contraction timer, OCR, which is a way to manually scan a paper chart into the app, and digital badges just to encourage daily app use. If an expectant parent does not have access to the app or a desktop, they can also kick count with our free downloadable kick counting charts in multiple languages by going to our website, www.counttthekicks.org. Next slide, please. Continuing with the app, and this is huge, I hope you're paying attention. We are so excited to share more about the Ask Anna feature on the app, which is an AI-generated assistant that provides instant research-based responses to questions about baby's movement, providing additional autonomy and advocacy for expectant parents using the free Count the Kicks app. Not only is this AI feature available on the app, users can also use this feature on our website and social channels. It's important to note that Ask Anna only curates answers from research that we have provided and vetted with our medical advisory team. Ask Anna is not providing responses from places like Google or TikTok. As always, it's important to highlight that this feature is not to replace medical providers. And in fact, Ask Anna encourages app users to seek the care of their providers whenever they have a concern. Users can not only chat Anna questions, they now have the option to call Anna and speak to her in any of the 24 languages currently available on the app. I did this yesterday. I've tried it out. It's so cool. Go in and call Anna and ask questions. So hopefully you have it downloaded on your phone. If not, my call of action is to do so right now, today. We want to thank and give a shout out to the Iowa Department of Health and Human Services. All Count the Kicks print materials are free in our state and free in an additional 30 plus states around the nation with different funding partners. We have both traditional and at-a-glance materials available. Also, fetal movement monitoring bands can be used with our paper kick counting charts if accessing the app is a barrier. We encourage you to use the QR code now to ensure that you have the most up-to-date resources and to ensure you have the kick counting conversation in every touch point in the third trimester. I'm also excited to highlight how your organization can lead the way in implementing evidence-based practices that save lives. First, A1 has had major updates to its fetal movement education module. These changes are now emphasizing that structured fetal movement education should be a part of the standard of care, and they support the use of digital tools like apps to help engage pregnant patients in daily kick counting. This is where the Count the Kicks Champions program comes in. The Champions program is a strategy for organizations like hospitals, clinics, public health department, WIC programs, home health visiting agencies, other community-based organizations that want to standardize fetal movement education system-wide. When an organization trains champions, they're building internal capacity to educate both patients and peers, reducing variation in care, aligning with national standards like A1, and ultimately helping to prevent stillbirths, which is why we're all in this room today, and the outcomes of moms and babies matter. And here we see, next slide, the living proof that Count the Kicks is a solution that works. We invite you to save babies from preventable stillbirth with us.
Thank you, Jen. We appreciate you being here. And next, I would like to introduce Ebonie with the Iowa Black Doula Collective. Ebonie?
Hello. I'm sure you're wondering, who is the Iowa Black Doula Collective? We are a movement of Black-led, Black and Brown birthing, Black and Brown serving doulas and birth workers fighting to help communities' voices be heard. The Iowa Black Doula Collective is an accessible resource that connects expectant parents from underserved communities to our seasoned doulas who share similar identities and experience through prenatal, labor, and postpartum experiences. Our doulas historically support and encourage expectant parents with data-forward, identity-affirming, compassionate, and comforting practices. Next slide, please. IBDC comprehensively trains both experienced and aspiring doulas in birth and postpartum doula education, lactation education, and parent self-advocacy, so that clients experience a smoother, more peaceful, affirming birth experience. Our goal is to foster low barrier entry to birth work education, kinship, and community conscious care so that those who need services the most receive them. For families who experience institutional unfairness and cultural incompetence in traditional birthing settings, the Iowa Black Doula Collective is your biggest advocate. Next slide, please. We are community-rooted, culturally grounded, and radically committed to reducing Black maternal health and infant mortality in Iowa, where Black moms are 6 times more likely to die from a pregnancy-related cause, 3 times more likely for Indigenous people. And Hispanic people also have a high rate of pregnancy-related deaths. Next slide. What we do, we offer free and low-cost birth and postpartum doula care to Black and Brown birthing families in across Iowa, thanks to our scholarships and programs and generous donations. Our trained doulas provide prenatal education and advocacy, birth support in hospital, homes, and birth centers, and postpartum care. We don't just show up for births. We build trust. We protect body anatomy, and empower families from the first trimester through the 4th trimester. We also train and mentor Black and Brown birthing doulas, building a pipeline of culturally competent providers and economic opportunities in our community. Next slide. Why it matters. Black and Brown birthing mothers in Iowa are facing a crisis, one of the worst maternal health disparities in the country. But here's the truth. Doulas can reduce birth complications by 39%, lower C-section rates, and increase breastfeeding initiation rates, and lower labor nurse burnout. Our work is literally saving lives. We are building joy. We are reclaiming the power of birth in Black and Brown communities. Next slide. Our impact and our vision. Since launching in 2020, during the middle of a pandemic, we have supported over 200 births, provided over 1,000 hours of postpartum support, trained over 70 new Black and Brown doulas, started a virtual mental health support group, started a lactation support group, and raised over $600,000 that have gone directly back into our communities throughout Iowa. But the demand is outpacing our resources. We have families ready, we have doulas trained, and what we need is you, our partners. Your investment can fund more doulas, expansion for rural areas, increase scholarship opportunities for families, and allow us to reach more families throughout the state of Iowa. Next slide. Our ask. We are inviting you to stand with us in this work, not just as donors, but as co-creators of a future where Black and brown birth is safe and is celebrated. Let's shift the outcomes. Let's find the joy, because when Black and brown moms thrive, communities rise. Are you ready to see Iowa thrive? Thank you for your time.
Thank you so much, Ebony. I loved that, the thriving and joy, and technically you have 2 minutes left. So you could have definitely said, feel free to wave or do anything else you'd like to share.
I am so sorry. I'm a fast speaker.
You're good. You're good.
Okay. I'm going to utilize this 2 minutes very wisely.
Do it.
I want to also recognize that we have a lot of community partners that allow us to give back to the community throughout the year. So we have community baby showers. We also have a postpartum box that we send out to families when they attend our mom's mental health support group. That group is led not by a doula. It is led by a Black mental health therapist. It is virtual to make it accessible to all families who register. If you want to find out more information, please go to our website. Go to our social media page. We have lots of resources available there as well. And I will give you back your time. I will also say, because Brittany just put in the chat, I'm also on the board for PSI, which I love being a part of, Postpartum Support International, and making sure that we are well equipped to give back to the community in a way that is needed.
Thank you. We saw a lot of emojis and things in the chat, so thank you for that. I really appreciate your time and being here today. So let's keep moving along, and I'd like to introduce, I want to make sure I get it right because I think that's important. Is it Nafla?
It is Nafla, yes.
Perfect. Well, take it away. The floor is yours.
Perfect. My name is Nafla Dainty. I'm the maternal health coordinator at Iowa HHS, and I am going to talk to you a little bit about the Iowa 2024 maternal mortality report, which covered deaths that occurred between 2019 to 2021. Next slide, please. Before we start, I would like to present a mock case summary for you. Olivia is not a real Iowa death. However, there are facets of her story that are from real deaths. So Olivia was a 25-year-old woman with an uncomplicated health history. She lived in a rural county and worked at a local elementary school. She was privately insured and saw a local family practice physician for her prenatal care, where she attended all of her prenatal visits. She had miscarried previously, and so she was over the moon when she delivered a healthy baby boy at 39 weeks. Her recovery was uneventful, and she and her husband were settling into being new parents until about 18 days postpartum. She began to experience chest pain, shortness of breath, and difficulty breathing. As her condition worsened, her husband called 911, and the hospital's one ambulance crew was already out on a call, but police were dispatched to her home. Her local police department responded quickly, but she had stopped breathing shortly after police arrived. CPR was started, but the police department's training and equipment was not as advanced as the EMS crew, and they lacked the ability to transport her to the hospital. The officers and her husband did all they could until the ambulance crew arrived 16 minutes later. Unfortunately, she was unable to be revived, and she passed at the hospital. Upon autopsy, she was found to have a pulmonary embolism, and she was also found to have a genetic blood clotting disorder, which was unknown to her family and healthcare providers. Next slide, please. So our Maternal Mortality Review Committee reviews all pregnancy-associated deaths that occur among Iowa residents. And so Olivia's story would be reviewed as it was pregnancy-associated. We view that as within 1 year of the end of pregnancy, regardless of how the pregnancy ended and regardless of cause. But if it's a pregnancy-related death, that is, again, happening in that same time frame, but the review committee has determined that a chain of events related to pregnancy is what initiated the death. So in Olivia's case, the review committee determined that had she not been pregnant, she likely would not have had the pulmonary embolism and would not have passed. But it doesn't necessarily have to be directly from pregnancy. So postpartum depression, had she not been pregnant, she would not have had postpartum depression, had the hormonal shifts, and may or may not have died by suicide. We also review pregnancy-associated but not related deaths, and I am not going to talk about those much here today, but those would be dying within that same time frame, but the cause is not related to pregnancy. So one that we see semi-often is, say, like a motor vehicle death, where had she not been pregnant, she would have still been driving and died. Next slide, please. So just to go through the number and timing of pregnancy-related deaths, our focus is going to be largely around those pregnancy-related deaths. Between 2019 and 2021, the MMRC determined that there were 20 pregnancy-related deaths among Iowa residents. And if you could click the next two slides over, it'll give us some boxes. So the majority of our Iowa pregnancy-related deaths occurred postpartum, in that postpartum period, and of these postpartum deaths, 25% occurred after 6 weeks postpartum. And one more, perfect. And next slide. So the causes of death and pregnancy-related deaths, I will admit that this period is a little bit skewed, as we did have COVID-19, and that did drive a significant number of our infection-related deaths. So 30% of our pregnancy-related deaths were related to infection, 20% to hemorrhage, which excluded aneurysms and cardiovascular accidents or strokes, and then 20% to embolism, excluding amniotic fluid embolisms, and then 30% to other conditions, which included cancer, those cardiovascular conditions, hypertensive disorders, and mental health conditions, which include substance use disorder. Next slide. And this is my biggest impact slide. The MMRC determined that of those 20 pregnancy-related cases, 95% were preventable. Just going to let that sink in. Next slide, please. The MMRC also compiles recommendations in 4 different levels of action for providers, facilities, communities, and systems. And here is a quick snapshot of some of the recommendations that are included in the report. So for providers, these 2 are mainly focused around OB providers, facilities, largely healthcare facilities. Next slide. Systems, so that is focused on policymakers, and then systems like Iowa HHS, Medicaid, things of that nature, and then communities, so community organizations. We do also do patient and family recommendations, but we rarely see those because the burden to change is on higher levels. Next slide. And my call to action would be to scan and utilize the maternal mortality report there. But then also, if you would like myself or our chair or another team member to present, please reach out. Or if you would like to have a full list of recommendations, please reach out to me.
Thank you, Nafal, for sharing that data and really shocking findings. We appreciate you being here today. Next, I'd like to introduce Jody with Luna. Jody, you are up.
Good morning, everyone. My video doesn't seem to be working, but I am the domestic violence program coordinator with Luna. And I have been with Luna for just over 10 years. And I've worked directly with survivors of domestic violence, sexual assault, and human trafficking for nearly 13 years. Luna works with Latino identifying survivors. We are one of the culturally specific domestic violence agencies that serve survivors in Iowa, and we support survivors across the entire state. We offer counseling, safety planning, support groups. We work with court processes, whether that's civil, criminal, or immigration court processes. We connect to partners within the community. And I want to give a little shout out to our partners at EveryStep, Count the Kicks, and Iowa Black Doula Collective. And I also ask for just a little bit of forgiveness because I'm allergic to Iowa. We focus primarily on sharing information. Most of the people that we work with come from other places and have limited knowledge of options and resources that we have to offer here within the state of Iowa. One of the very concerning trends that we've seen since COVID is that when people come to see us the first time, they're usually experiencing a level of violence that is more severe. They have injuries that are more concerning, and they have safety risks that are more impactful than what they did several years ago. That takes our process from forming a plan and establishing safety to scrambling to find some level of safety for this family who's just experienced a violent event. Survivors within our community often reference reproductive abuse, which goes right in hand and aligns with maternal health. Often the first incident of domestic violence, of physical domestic violence, occurs during pregnancy or shortly postpartum. We believe that that's due to increased vulnerability and increased economic dependency that survivor may have on the abuser. Within Latino cultures, a woman having a man's child can lead to feelings of ownership, and that enhances that power and control imbalance. We have offices in Des Moines and in Marshalltown. And while we are culturally specific, we are not culturally exclusive, which means that anyone that seeks services with our agency will be provided those services, regardless of their cultural identity. We try to share quite a bit of information whenever we have families that are expecting a child. We have a whole stash of Count the Kicks information, because that's a concept that most of our communities who's recently arrived, they aren't aware of that. It's not a best practice or standard practice in the places that most of our community members come from. We try to directly connect with as many of the survivors that we can. Though because we are limited in our staff, we're a small agency, we follow a model called co-advocacy with our partner agencies. For example, if we have a survivor in Davenport and that survivor is needing culturally specific services, we generally would then provide the counseling and resources via phone or video call and connect with our local partners to get local resources. Advocates know their communities, and the advocate that works in Davenport knows where the best resources are available in Davenport, so that collaborative relationship has enabled us to serve more and more members of our community. And look at over the last 3 years, we've partnered with the United Way to provide mental health education, including workshops and support groups. And we are seeing the trends of increased food vulnerability, food instability, housing instability because of rent prices. And we struggle sometimes to connect with people who don't have access to technology. We take for granted that members of our community have telephones and have access to the internet. And as a statewide agency, some of our rural communities have limited access to internet services. And again, that's where we partner with our local advocates. Just looking at the notes. There is frequently a cultural perception that anything that happens during a pregnancy, anything that happens to a child, within the community, within the culture, everything is the mother's fault. If a child is colicky, say you have an infant and that child's colicky, it's because the mother was angry during her pregnancy. We see that kind of fallout from any kind of special needs or disability that may present at birth. Denial of paternity is an abuse tactic that can be very impacting on the safety of any new mom and those children. Aside from our focus of domestic violence, we also do a lot of support with sexual assault. We have a group of counselors who serve only children from 11 to 17. And in those situations, we generally will have the child survivor work with a youth advocate, and then an adult advocate will work with the parent and support that parent through the court processes, ensure that the family is connected to crime victim compensation programs that give them access to therapy and medical care that may be needed for the victim. It is increasingly concerning to us that primary incident of violence that happens in a pregnancy and the correlation that we see between domestic violence and reproductive abuse, with changes in policy and with changes in law, reproductive abuse and an unexpected pregnancy can be a huge barrier to a survivor who's looking to find safety. And the correlation of all of the programs and all of the agencies that have come here together help to support a survivor who may unexpectedly find herself pregnant, may unexpectedly find herself facing being single parent when she hadn't planned on being a single parent, and help families build towards safety. It's kind of an abstract concept, so I want to just throw out like a scenario. Say that Maria has been preparing to leave her abuser for 6 months. She has 3 children under 5. She puts a deposit and first month's rent on a new apartment where she's going to move with her family. And the day after she moves in, she finds that she's unexpectedly pregnant again by her abuser. We would immediately reach out to our partners. Immediately. EveryStep has wonderful programs that support parents throughout pregnancy. We would reach out to Lighthouse for young moms and get those families supportive housing services. We would reach out to Health and Human Services and help that family to apply for any safety net programs that they may be able to qualify for. we would connect that survivor to Iowa Legal Aid to explore her options to establish custody and child support for her child. We would connect that survivor, Maria, to a immigration attorney to look at a consult to see what options for long-term safety could be. She may not feel comfortable going into a hospital environment to have her baby, so we would definitely share the Iowa Black Doula Coalition's information. And with every family that comes in, I specifically, and I believe most of our staff, share Count the Kicks information. I am a living sibling to a baby brother who was born sleeping. And that not only affects the mother, the father of that child, it affects an entire family. We want to make sure that these babies come into the world as safely and as healthy as possible, and make sure that moms and dads have the information that they need to do that. I'm not a parent myself, so I've actually had to learn through a lot of the presentations that we do. We have very specific conversations about safe sleep, the use of appropriate child restraints, rear-facing restraints. Please don't put your 5-year-old in the front seat. They can be your bestie from the back. We do struggle, I think, as does every domestic violence and sexual assault agency currently, from lack of resources and limited support. It is very easy to say we can't solve a problem with money, but my call to action is it costs money to find safety. So I am going to put my contact information into the chat here really quick. And we have electronic brochures and information that we can share out, and we'll be happy to do so. And I hope you all have a great day.
Thank you so much, Jody. That was a great conversation about that cross collaboration that we have together and how we can all work together and provide services. And so I really appreciate that and sharing your story with us today. Yes, please share all your digital handouts. We will send out an email with all that, so everybody will have that. And we just appreciate your time and passion and love for the people that you serve. So thank you so much for that. We're going to continue the conversation now with Monsoon and Audrey, who I also have worked very closely with over the last couple of years, just like I have Jody and EMBARC and everybody else on this panel. So Audrey, take it away.
Thank you. Thank you for that introduction. My name is Audrey Luyolkin, and I oversee the transitional housing and community health programming at Monsoon Asians and Pacific Islanders in Solidarity. This Ignite presentation is called The Invisible Struggle, Maternal Health in Iowa's API Communities. Next slide. For those unfamiliar with Monsoon, we are a culturally specific nonprofit organization that serves victims and survivors of gender-based violence, very similar to Luna, domestic violence, sexual assault, human trafficking, but in Asian and Pacific Islander communities in Iowa. We serve all 99 counties. We have 3 different offices. The main office is in Des Moines, which is where I'm located, but also Iowa City and Dubuque. There's several programs, next slide, but the heart of what we do is in direct services, meaning one of our multilingual advocates will walk beside a survivor in different needs, like medical visits, legal meetings, court hearings, housing, other services. The program we're talking about today is going to be under our community health program, which stemmed from a need from survivors seeking more culturally specific wraparound services, including maternal health. Next slide. A quick snapshot of Asians and Native Hawaiians, Pacific Islanders in Iowa. There are 88,000 roughly Asians in Iowa, 6,300 Native Hawaiian Pacific Islanders, so around 3% of Iowa's population. If you're a visual learner like myself, you could essentially fit us all into one very large football stadium. Next slide. While we make up 3% of the population, our communities face very unique barriers in maternal health care, lack of language access, cultural differences leading to mistrust with the healthcare system, which leads to many challenges. In this chart, this shows the maternal mortality ratio from 2016 to 2018. This is from HHS. During this time period, we trailed Black mothers as the highest maternal mortality rate in Iowa, when again, we only make up a sliver of the population. Now, the latest maternal mortality review report that NAFLA just touched on from 2019-2021, there were no reports of pregnancy-related deaths from the API community. But from a data standpoint, next slide, APIs have among the highest severe maternal morbidity rates in Iowa, meaning any short or long-term health problems that result from being pregnant and giving birth. With the help of Debbie Kane, she's the maternal health epidemiologist from HHS. She pulled up the most recent data from maternal morbidity in Iowa. These conditions here that are in bold are the most prevalent conditions in the US according to the CDC. Next slide. There's also an explanation of how severe maternal morbidity rate is calculated. If you're interested, you can look at that later. Next slide. But if you can see here from 2018 to 2020 and from 2022 to 2024, the severe maternal morbidity rate has increased by nearly 20%. Next slide. This is a breakdown of the severe morbidity rate among ethnic groups. Again, the kind of dark blue that represents Asians and Pacific Islanders, the orange represents Black mothers, and then the green represents white. You can see that Asian mothers were consistently higher than white mothers of severe morbidity rates, right alongside or right below Black mothers. The statistics are alarming, yet our issues stay mostly invisible because our numbers are technically, statistically insignificant. Right? Ratios are big, but individual cases are small. Remember, there's not many of us, so red flags are not being waved, and our communities are mostly unaware of this, which means birthing individuals are experiencing harm because of it. Next slide. This is another chart showing the severe morbidity, maternal morbidity rate. Next slide. So what do we do? Knowing this information, combining it with the findings from a needs assessment from 2022, which showed API mothers sought spaces for support and increased awareness for services, Monsoon started building our maternal health programming in 2023. Next slide. This is our team. We are a small, mighty team of 2 mothers. That's my counterpart, Violet, on the left. And our 4 very young children, not photoed, is baby Leo, who is 4 months old. We probably should update that photo. But our work is very personal. We are the mothers that we serve. Between the 2 of us, we've experienced many of the conditions listed on the severe maternal morbidity list. And unfortunately, the support systems that we needed did not exist. So we as mothers, as community health professionals, are building what we need. And this morning has been so great because there's so many others out there that we need to connect with. But we're building what our sisters need, what our cousins need, what our friends need. And really, it's a collective effort. Next slide. Our community maternal health programming is community driven. It's culturally grounded. We focus on wellness with different maternal care strategies. These spaces center the experiences of Asians and Pacific Islander mothers, but we are open to any individuals or caregivers who find support or belonging in our spaces. Many times we center the experiences of mothers of color. So many times participants come from all different communities. This is kind of what it looks like. There are a lot of different offerings, monthly gatherings for parents, informal playdates, opportunities for parents and caregivers to learn, health clinics, baby gear exchanges, postpartum support. Next slide. Whatever program we offer, it's important that we constantly evaluate our programming to ensure it's rooted in community and following the leads of mothers. These next couple of slides will just be photos of some of our events. But while Violet and I, we are Southeast Asian between us, we're Thai Dam, Lao, and Vietnamese. We only make up 3 of the different ethnic groups that we represent. So it's important to remember that our groups are not homogenous. So constantly asking for feedback of how our communities need support, reflecting on how our communities digest information, how our people pass along good information about pregnancy, labor, birth, postpartum. I want to emphasize that we are all different. How wisdom and knowledge is shared through API communities is similar, right? Our sisters, aunties, grandmas, mothers, we all are carriers of maternal health knowledge. This info is usually passed to each other through like around a table or in a living room, many times around food. So incorporating that familial communal piece into our program delivery is so vital. And so at the end, our ask is to not brush over the experiences of Asian and Pacific Islander birthing individuals in this work. We are technically defined as statistically insignificant because of our small numbers, or the levels of severity aren't as prominent because aggregated data masks potential issues. But just remember that data is not enough to inform change. These experiences are very real, and the needs of these birthing individuals need to be lifted up. This is our contact information. Feel free to reach out to me if you have any questions regarding data. Debbie's email is listed as well. Thank you.
Thank you, Audrey, so much for taking your experience and turning that into action and being a valued community partner. We really appreciate you being here today. Next, I would like to introduce Brittany with Postpartum Support International, the Iowa chapter. Brittany, you are up. Take it away.
Hi, everyone. So my name is Brittany Haskins. I am the chair of Postpartum Support International's Iowa chapter, and I do childbirth education at Unity Point Health Des Moines. Looks like my slides are out of order, and that's okay, because thankfully this is not the first time you're hearing about perinatal mental health today, nor will it be the last. But PSI is the leading international organization to address parental mental health. It was started in the 80s. It's in all 50 states and 49 countries. So your Iowa chapter was incorporated in 2018. So mental health, who cares? Well, Christina Broadlawns already gave us a great overview of the statistics. It is the #1 complication of childbirth and pregnancy. And even if you don't have a living child, that doesn't, save your brain. It actually probably makes it way worse. So we're looking at truly everyone who ever becomes pregnant is more at risk for mental health issues. And 75% of those who do reach that 1 in 5 stat of having a diagnosable condition will not receive treatment. Economically, this is terrible, really, for everyone. But even here in the state of Iowa, it's over $36 million that it's costing resources in the state because we are not treating these moms and these families who so desperately need help. So, that's fine. Leave it. Go back a little bit because I think my first ones are just gone. Mental health is health, you guys. You know that. But all of the physical parts of pregnancy affect your mental health. You cannot extricate one for the other. So when we call it maternal health, we are also talking about mental health. I think you get that. So what does PSI have for you? I know we have many providers on board. And when I'm saying providers here on this slide with trainings, it's not just OBGYNs, family medicine providers, doulas, nurses, lactation consultants, anyone in the patient-facing space. We have trainings for you. So I am in childbirth education. The first person we tell people to go see if their brain's not feeling great is their OB. And so let's say they do finally get the courage and they're going to be brave and they say, hey, I need help with my brain. And the OB says brain, psych. And psych says postpartum, OB. So it's this really unfortunate cycle that we want to stop and really help both sides with that, but mostly getting providers the training for their patients' mental health. So there is actually a certification program through PSI called the PMH-C, or you can just go to postpartum.net. I'll have that info at the end and you can see what trainings are available. Next slide. So if you are a provider, if you're a friend, if you're a sister, if you might be pregnant yourself, I just need you to know, please don't take yourself or your patients off of their mental health medications just because someone becomes pregnant. These are decisions that need to be made with ideally a perinatal psychiatrist, but we are not just randomly yanking people off of meds for the sake of the fetus. Many times, most times, the risk of, let's say, a general SSRI is far lower than the risk of a person who is not on their mental health medication. If you would like to know more about that, please go to mcpatformoms.org. There is so much free information about medications and pregnancy. I'm going to tell you the stat that keeps me up at night that I heard last month. In the MMRC report data from Colorado, so you just heard about Iowa's, in Colorado, they dug into theirs a little bit more. 48% of completed suicides were from mothers who had been told to go off their mental health medication by a healthcare provider. Let that sink in. That is scary. Yes, PSI is doing something about that. Next slide. Okay, resources for parents. So all of you who are like, I don't actually see patients, or hey, I'm in the thick of it right now. We have so much free stuff for parents. So PSI has a free helpline and text line in both English and Spanish. We have well over 50 free online support groups. Those are also in English and Spanish. They're working on more languages for us. But this is a really great resource for if you are on the waiting list to see a therapist, if you are going to those really great in-person monsoon meetups, but you need help today. You can log on. There's over 50 of them. There's probably a free one going on this afternoon that you can log on to. There are support coordinators for some really niche situations. If you have a patient on long-term bed rest, they can be connected with a support coordinator. Parents with eating disorders, deaf parents, API parents, military families, LGBTQ, just please go to postpartum.net, look at all the free offerings. There's a peer mentorship program, and then there is the chapters program. That's us. You can get connected to what we're doing here in Iowa. Next slide. And then tell people. So for you, I have through PSI flyers, brochures, clinic posters, English and Spanish, magnets, pens. We have mental health discussion tools. We have lunch and learns. We would love to come talk to you. We're going to need more than 6 minutes to explain this all to you. And we do have presenters on a wide range of mental health topics. So if you are a prescriber, we can get a really niche doctor to talk to you about psychopharm in the perinatal period. Or if you just have a mom support group and you're like, we want somebody to come talk about that experience, we have a wide range of presenters. Please reach out. We would love to talk to you more, all free. Next slide. And our call to action, please connect with us. However you would like to do that, there's a bunch of ways. So if you would like to subscribe to our chapter newsletter, there's the URL, or you can scan the QR code. That newsletter every month has a list of all the in-person postpartum support groups that we know of happening in Iowa. We would love to add more if you have one and it's not on your list. We're on LinkedIn, Facebook, Instagram. We love to tell people's stories. If you feel called to share your postpartum mental health story, please reach out to us. There's the email, and we would love to elevate that on Facebook, on Instagram, however you feel comfortable, because how we reduce the stigma is by sharing our stories. So please, however you would like to connect with us, take a picture of this slide with your phone, subscribe to the newsletter. I hope to hear from absolutely every single one of you that you want some magnets or some pens, and to help us with our advocacy work to get a state perinatal psych access program approved legislatively this session.
Wow, thanks, Brittany. So when we talked about technology and things like that, we've had tech issues, we've had slides, and look at you just go, you're a pro at this. So thank you for all of that information. Everybody, you heard her, she wants over 200 of you to contact her for magnets and materials. So feel free to do that. Brittany put your stuff in the chat there as well. And now we're going to keep on moving. I hope you guys have been taking breaks and stretching and standing. We have a couple other Ignite sessions left before we open it up to questions, and then our final presentation around 11. So we're going to bring back Lydia to the stage. Hey, Lydia.
Hey.
And Lydia's wearing two hats for this event today. So now she's going to talk about Scott County Health Department. So I'm going to pass it over to you again.
Hello, can everyone hear me?
Yes.
Okay, I had to switch my location, so hopefully this is better. But hello, everyone. I am Lydia Harris again. I am with the Scott County Health Department, and we will be talking about our maternal health program. Next slide. So Iowa's Healthy Pregnancy Program provides education and support to pregnant and postpartum women at no cost. These enhanced services are beyond what clients receive with prenatal care. Next slide. So the Healthy Pregnancy Program offers services and supports to address the following. Just going to name a few: no insurance or underinsured, transportation barriers, oral health concerns, so getting them connected with the I Smile program, and dental services, poor social situations, mental health, food, breastfeeding, and so on. Next slide. So we try to see them at least once during the first, second, and third trimester, but a lot of the times we get them in the second trimester, or even in the third trimester. So we will do what we can to help. We'll make sure that they have access to insurance. And so we will do the presumptive eligibility with Medicaid, same day results, making sure they have access to that pharmacy and ambulatory services with the emergency Medicaid. Connect to OB providers, dentists, and resources. We will sit on the phone with our clients and make sure that they can make their first appointments to any of those things that they need. Education, our psychosocial, and then we do some assessments like our drug and alcohol, depression, adult abuse, and we also offer the listening visits as well. Next slide. So we do have a weekly presence at some of our OBGYN clinics, our CHC Edgerton and the group. And then we do provide lactation classes virtually and also at Pregnancy Resources that is located in Davenport. And we do service Cedar, Clinton, and Jackson counties and accepted referrals from WIC and OBGYN clinics and our community partners. Next slide. So outreach, we do a lot of outreach. So like I said, we do our lactation classes at Pregnancy Resources. We also have done some classes at our at the Pregnancy Care Center in Clinton, so providing that safe sleep education, tobacco use in pregnancy, and then dental hygiene in pregnancy. We work with our local high school, one of the local high schools, to provide safe sleep, tobacco use education, and then dental hygiene education. And then they did have a girls mentoring group that we would meet with, and so we would try to work with any of the moms who were pregnant, just empowering them, giving them resources, and making sure we were walking alongside them during their pregnancy. I am the chair for our local NAACP, so we have done some events with NAACP. We've done a Black Breastfeeding Week, and then we did our Women's Health Forum as well. The Lincoln Center is our local community center, and we have done a huge community baby shower with them for the last 3 years. And during that time, we've provided blood pressure checks and dental screenings. And then we, of course, do a lot of community events and health fairs to get the word out about our healthy pregnancy program. Next slide. So the community baby shower. So like I said, we partner with our local community center. They usually do a back to school block party. So they'll be outside and in parts of the building, and then we will have our community baby shower in our community room and in the gym. And so it's a great way. It's like a one-stop shop because the parents get to bring their kids to do get backpacks, get food, get if they have to get physicals, they'll do that as well. So we see about 150 to 250 participants each year. Like I said, we do the BP checks and the dental screenings. And then, of course, we do tons of giveaways and door prizes. Usually on our planning team, we'll have Molina, Iowa Total Care, Scott County Kids, Every Child, WellPoint on our planning team to make sure that this goes smoothly. Next slide. So we have our Healthy Pregnancy Coalition that also is ran through our health department, and I'm the chair of, and facilitator for this group. And so it's just an alliance of community members, stakeholders, partners that are working together to help reduce maternal mortality rates and maternal health disparities in our community. We meet quarterly. We have about 45 coalition members. This year we focused on preeclampsia and held a promise walk with the Preeclampsia Foundation. Next slide. And so these are just our partners that are part of the Healthy Pregnancy Coalition. So you might notice a few on there. Next slide. You can go to our next slide. Oh, and then I don't know if I think there is a slide miss. Oh, there we go. Yeah, so we did do our promise walk like I mentioned before. That was this year. Again, like I said, we partnered with our Preeclampsia Foundation. We had 35 participants. We were at the park. It was hot, but we did do some laps and bring awareness to preeclampsia. And so that was a great way to connect with our community members. We did have a midwife come and talk about signs and symptoms, and we had some of the hospital systems represented and the clinics, they were there. And so we were glad to host this event. Next slide. So that is all that I have for what we are doing in Scott County. If you have anyone that or know of anyone that lives in the Scott County area that is in need of some resources and support, please contact us and we will make sure that we get them connected. Thank you so much.
Thank you, Lydia. You are busy and we appreciate you and all the work that you're doing. So thank you so much for being here today and explaining about all the great work that you're doing. So, okay, next we have Michelle with the Siouxland District Health Department. Michelle, take it away.
Hi, everybody. Good morning. Lori Atkin, who is our public health nurse and STI clinician, was going to be giving this presentation this morning. However, she was unable to make it. So I am filling in last moment. We will not have any additional slides other than the one that you see on the screen. So as mentioned, I am Michelle Lewis. I am from Siouxland District Health Department. We serve as the public health department for Woodbury County, which is in the very northwest corner of the state of Iowa. And so I'm going to be talking to you today about kind of our STI program and how we've worked with our maternal health population. So I do have some notes on my desk since we have not been able to make slides for the presentation. So just to kind of give you some feedback, back in 2021, we were doing our community health needs assessment for Woodbury County, and we knew that STI rates in the county were high. We had the highest gonorrhea rate in the state. We had the second highest chlamydia rate in the state, and we had the third highest syphilis rate in the state. And so they were on our radar. We knew that STIs were bad. So we formed a STI coalition and we added that to our health improvement plan. We were going to work on that for the next 3 to 5 years, focusing on just general STI education. Our coalition does meet every other month. And so we continued to look at that data on a regular basis. Slowly, we were beginning to see that those syphilis numbers were creeping up. And so by 2023, just a year or two later, we had over 158 cases. So in 2020, we only had 12 cases. By 2023, we had 158 cases. And so basically we had 5 times the state rate. So we knew we had an issue. Talking with people at the state level, they pointed out the fact that they were seeing that typically syphilis is prevalent in men having sex with men. However, in Woodbury County, more than half of our syphilis cases were amongst female clients. And so we were concerned about that because then we started to see congenital syphilis. So in that 4-year time frame from 2020 to 2024, we had 12 babies born with congenital syphilis here in Woodbury County. And so we kind of shifted from the general overall view of STIs in the community to really looking at syphilis, congenital syphilis amongst our maternal health population. So from that, we started reaching out to our local offices. We wrote letters to them, our OBGYN offices, our hospitals, that type of thing. We were doing podcasts. We were doing interviews with our local media just to kind of get the word out. Like, this is a really, bad issue in our community. So then we hosted our first ever public health roundtable. That was on syphilis. We had over 30 different practitioners come in to listen about what was going on, the why we really needed their buy-in to start really screening and testing more frequently and whatnot. So by the end of that roundtable and some additional planning, we then had all 3 of our OBGYN offices now testing during the 1st and 3rd trimester for syphilis, which was great. Our birthing hospital was on board. They were testing at all deliveries. So we thought we had made some great system level changes and we were, making progress. We were still seeing babies born with congenital syphilis. And what the hospital was reporting back to us is that there's still a handful of people that are not seeking prenatal care. So no matter what we're doing with our OBGYN offices, medical teams, that type of thing, we're still missing a segment of our population. So at that point, we then had a brainstorm. How are we going to reach the population that's not seeking prenatal care? And so one of the suggestions was potentially to work with our women, infant, and children, our WIC program in our county, because they still saw a good chunk of the pregnant people were still going to their WIC appointments prior to delivery. Fortunately for us, our WIC program in Woodbury County is housed right here at our health department. So we reached out to them. We kind of had a lot of meetings. It was a long process just because we're working with, the WIC and their regulations. And so we also had a standing order for the health department that we did not test or treat pregnant individuals. We required them to go see their provider for that. So we had a few hurdles we had to get through, but all said and done, we finally got our standing orders changed. Our Board of Health was on board and our WIC CPAs were on board so that we can now start screening individuals that were coming to their WIC appointment that were pregnant for STIs. So how that worked is anyone that came in for their pregnant certification appointment for WIC were being asked, have you seen a client, or excuse me, have you seen a provider, medical provider for this pregnancy? If they had said no, they automatically then got referred to our nursing clinic after their WIC appointment. If they had already seen a provider, then they were not sent back. If they said, well, I have one, but I'm going to see him in about, a week or two, then they still got sent back. So long story short, they would go visit with our STI clinicians, which Lori was one of them. They were kind of do a brief synopsis of what the importance of STI testing is. And then hopefully they would get tested. So overall, we have tested over 130 or so individuals. And then we've had about 2 or 3 positives. So, not a lot of positives, but at least we have caught a few in that time frame. Overall, in the last year or so, county-wide, we have just been notified from state that Woodbury County has seen the largest drop in syphilis amongst any of the counties throughout the state with a lot of these initiatives that we put in place. So just glad to share that our partnership with WIC is working and we're able to screen people that would not have technically gone out for prenatal care, have sought out prenatal care, got STI tested before delivery. So that is all I had to share today. So thanks for having us.
That's amazing. Thank you so much, Michelle. And if anybody has questions, remember the contact information is on our website for speakers, but also you can put those in the chat and speakers have been answering those specific questions for them. And then we should have about 10 minutes left for other questions that we have before we close. So thank you for sharing that. Next up, Young Parents Together Success Tree with Brooke and Jill.
Good morning, everybody. I am Brooke Olson. I am the Assistant Director with SuccessLink and here today with...
I'm Jill White, the Coordinator for Young Parents Together.
And our Young Parents Together program, so we are based out of Waterloo, Iowa, and we have operated a support and education program for expectant and parenting teens and their children for about 3 decades. Young Parents Together is a weekly support and education program specifically for expectant and parenting teens age 19 and younger, both moms and dads and their children. And we also have people who are expecting their first child who might be in their early 20s that can join our program prenatally as well. And we have about 85% to 90% of our participants each year that join our program prenatally. we have a really close partnership and collaboration with the Northeast Iowa Food Bank. We host our program every Monday on site there. And so our families receive a nutritious meal during our program when they arrive. And they also have access every month to shop the pantry at the food bank. And as we all know, with SNAP benefits being on hold, this has always been an important part of our service to our families and will continue to be a critical need each week. But we really are a partnership of many agencies. Our goals are to increase knowledge during pregnancy, childbirth, and parenting so that every child born to a teen will have healthier outcomes. And so we have a prenatal education group. Janelle that provides that is a lactation consultant and a former OB nurse and is currently a school nurse at one of our elementary schools. We have a newborn education group for parents who have babies up to age 8 months. And then once baby's turning 9 months, they go to parenting education. And that is facilitated by a home visitation, home visitor through Head Start. We utilize various curricula that meet the various needs of specifically of teens who are expecting and also parenting. And, one of our main things was really to talk to you today about maternal health from the voice of our teen parents. And so we're going to go to the next slide, and Jill's going to talk more specifically about what our teen parents are really saying about their maternal health experience while they're part of Young Parents Together.
And I just want to add before I share with you kind of through their eyes what maternal health has meant to them, that another key piece of our program, aside from our newborn parenting and prenatal, is we have a mental health licensed mental health counselor that also comes weekly as part of our program. And so really covers that vital piece of screenings. So, and talking to them about depression and what that looks like during a pregnancy and how, what some of the signs are, what the signs can be after, all those really critical pieces that we think are so important for the outcomes of our participants and their unborn and soon to be born children. And she does that up until their child is 2 years old. So that's ongoing. But through the eyes of our participants, we just think they say it best, how valuable their learning was. So really, these are their words on when asked the value of that maternal health piece that went through the prenatal piece when they were with our program, have shared when we asked what they valued the most in learning during that time. In their words, to prepare for live birth and newborn stage, how to change a diaper and soothe our baby. It helps us grow as a mother. I learned a lot about what to expect. You learn how to deal with giving birth and what it really means. I didn't know nothing, so it really helped me. As it got closer, my fear went away. I learned about labor and delivery and what to expect. I didn't know nothing. It taught me things about pregnancy that I didn't know before. Hearing other people's birth stories helped me prepare more as well. She will teach stuff I didn't know about becoming a mom, so I get more knowledge. And I was able to learn about different medications that you're able to take during labor. We also learned about different positions that you can birth the baby in. We also talked about what it could feel like during labor and in birth. And one of our participants shared one of her most valuable experiences was when she was sitting at the mealtime and our prenatal facilitator came over to her to talk to her because she saw her feet were up on the chair. And as they engaged in conversation, she shared that her feet were really swollen and that she'd been having headaches. And through that exchange in our weekly support group, our labor and delivery facilitator shared that she needed to go in to the doctor, and it was really important. So she did, and literally a day later had her baby. So or 2 days later, I apologize. So it was
Life-saving.
just like, she will say that saved my life and my baby's life. So, anyway, our 6 minutes is up, but those are some really things that we think are really valuable about our program with such an important age group. Thank you.
Thank you, Brooke and Jill. That is amazing. Thank you for all the work that you do for young families in the community. Next, I'd like to introduce Amanda with the University of Iowa, IMQCC. Amanda, take it away.
Hello. So I'm going to start by saying that we are now the Iowa Perinatal Quality Care Collaborative. This combines the Iowa Maternal Quality Care Collaborative, Iowa AIM, Iowa Neonatal Quality Care Collaborative, and the Iowa Obstetrics Mobile Simulation Program. We are now one entity under the umbrella of the Iowa Statewide Perinatal Care Program. This team is supported by Iowa HHS to provide quality improvement and safety support to Iowa's 54 birthing hospitals. And our vision is for all Iowans to experience care that is safe, respectful, and accessible. And I apologize, I do not have Crystal with me this morning. She just got back from Aruba, so I'm giving her the morning off. This is a picture of most of our team. We're missing Brenda Wolf and Amanda Wagner in this picture. Our IPQCC team is co-directed by Drs. Stephanie Radke and Julie Lindauer. Crystal Graves, Amanda Wagner, and I are the clinical nurse improvement coaches and simulation instructors. Nicole Anderson is our program manager, and Karina Smith is our program coordinator. And then Drs. Stephanie Radke and John Daigle co-direct the Iowa Statewide Perinatal Care Program. Penny Smith and Brenda Wolf are also on this program as clinical nurse educators, but we all work together to ensure that we're providing the highest quality care to our moms and babies in Iowa. Next slide. This is my favorite picture of why we're here. Healthcare moves at such a fast pace that sometimes we tend to just continue with the way we've always done it because that's the easy way. That's what we know. And we're completely unaware that a more efficient and effective way of providing care or maybe new evidence has come out and we're just continuing with what we knew before. So we try to push forward with those square wheels while one person innovation or process change holds those round wheels literally right next to us. So our goal is to take a step back, looking at both the evidence, current practices, and the data to determine how we're doing currently and then figure out what we can do to optimize the care we're providing. Next slide. So we do this in collaboration with the Alliance for Innovation on Maternal Health, or AIM bundles. AIM is a national leader in the development and implementation of these patient safety bundles to promote safe care for every birth in the United States. Iowa first enrolled in the AIM program in October of 2020 and is now one of 49 states participating. Our first AIM safety patient bundle that we did was the safe reduction of primary C-section. That began in 2021 and helped reduce Iowa's nulliparous term vertex singleton, or NTSV, rate to 23.2%, which is below the Healthy People 2030 goal of 23.6%. Since then, we've also worked on obstetric hemorrhage and severe hypertension in pregnancy. These initiatives are all in the state of sustainability right now. We utilize quality improvement methodology from the Institute for Healthcare Improvement and collaboration between hospitals to accelerate improvement. We use data. We rely heavily on data to track our improvement, just so we know that the changes we're making are actually contributing to a positive change. We also facilitate many team shares, as that is the primary benefit of being in a collaborative. You never feel like any health systems against one another, hospitals against each other. We're all working together to provide the best care that we possibly can. We're able to learn from one another, share ideas instead of reinventing the wheel. And again, there's just a little feeling of friendly competition between facilities, but we believe that only makes us better. Next slide, please. So our next initiative will begin in February of 2026, which is a combination of two AIM patient safety bundles, the perinatal mental health conditions and substance use disorder. as well as two of our own, the intimate partner violence and social determinants of health. We're calling this initiative the MOMS Initiative, thanks to ChatGPT, which you can see is short for Mood, Mental Health, Substance Use, and Social Support Initiative. This will be about a 2-year initiative in which we will tackle each of these topics one at a time. We'll start with perinatal mental health in February. Also, if you spoke about perinatal mental health today, you have now signed yourself up for a presentation with our MOMS Initiative. So congratulations, we'll be reaching out. We're also very excited. For the first time, we're going to be including prenatal clinics, as well as community birth midwives and potentially emergency departments in this collaborative. One of the things we found very eye-opening in our pilot was that many of us hospitals don't know what resources are available in our communities. So we hosted a community partnership meeting. Actually, Jill from Young Parents Network was there with us. But we brought together organizations that these hospitals and clinics work with to facilitate conversations on how we can better connect and work with our patients to get them to these resources. So we will be hosting 4 of these actually in different quadrants of the state. This is not a certificate training. This is just more so to facilitate conversations. But we're very excited to do that again. We learned a lot from our pilot. Next slide, please. So our simulation team is one of the major ways that we practice and reinforce the implementation of our quality improvement efforts. Crystal, Amanda, and I travel to birthing hospitals, emergency departments, both with and without obstetric units and EMS crews. When we travel to our birthing hospitals, we offer a simulation menu that team leaders can choose from to determine what would be most helpful in their facility. Many will have like a new hemorrhage or hypertension protocol they want to test, and we assist them in running a simulation to test that. In this first picture, this hospital had just started using the JADA device for postpartum hemorrhage and wanted to practice placement as it was now part of their stage-based hemorrhage protocol. We also reinforce the importance of quantitative blood loss to know where we're at in the hemorrhage and ensure that we're choosing the most appropriate interventions. Otherwise, we do topics related to severe hypertension in pregnancy, eclamptic seizure, C-section under local anesthesia, or any other high-risk, low-frequency kind of obstetric emergency. In the middle picture, we're running, The middle picture, we're running a maternal cardiac arrest scenario following an amniotic fluid embolism. Thank you to the AFE Foundation. They provide a free scenario that we were able to use. We actually called a maternal code overhead in order to get the entire hospital code team to respond. So that's why that room is just full. Many times we find that hospital rapid response and code teams are afraid to come to OB. And get this, their biggest fear is that we are going to ask them to deliver the baby, which by no means would we ever do. So once we explain that they are there to manage airway, breathing, circulation, they're more than willing to jump in. We often hear that one patient should never turn into 2. In OB, that's just our everyday life. And then in that third picture, Crystal is wearing what's called a Mama Natalie birthing simulator. She's actually bouncing down the road in the back of an ambulance. She's a very good actress, has very intense facial expressions. She's waiting for her Emmy. Therefore, she does get a heart over her face for this one. We are very firm believers in doing low fidelity simulations in their hospital room or in the ambulance that people can easily recreate when we're not there. In fact, we encourage them to run simulations consistently so that they stay up to date and practice in all these scenarios. It's muscle memory. We were very fortunate enough to be able to gift a Mama Natalie to each of the birthing hospitals in the state. And now we're working to distribute one to every critical access ED in the 33 maternal desert counties in Iowa. This is part of our new partnership with Simulation in Motion, or Sim Iowa. Our goal is to ensure that every provider, nurse, paramedic, EMT, first responder is equipped with the most evidence-based knowledge, skills, and confidence when caring for our obstetric patients. Next slide. And then my call to action is to engage with your state's PQC or Perinatal Quality Collaborative. We need your involvement and your support in order to thrive. Otherwise, thank you so much for having us. If you have any further questions or want to request a sim visit, please visit our website at iowastatewide-perinatalprogram.org.
Thanks, Amanda. I think you'll get some requests now. So, and I like that you're like, okay, everybody that spoke gets to present for PSI now. So awesome. Thank you so much. And we'll hear from Dr. Radke soon. But first, we're going to wrap up the Ignite sessions with Nicole Newman from WIC. Nicole, why don't you come on and take it away?
Hello, last but not least, right?
No, exactly.
Well, I am Nicole Newman. I'm the state WIC breastfeeding coordinator and also a nutrition consultant for the WIC program at the Iowa Department of Health and Human Services. I just want to talk to you a little bit today about the WIC program, benefits, projects we're working on, and how you can get involved with your local WIC agency. So next slide, please. Most of you know I've heard a reference to WIC a lot today, so I'm excited to hear that. But just for those of you that don't, I just want to go over a quick overview of what WIC is. So WIC is the special supplemental nutrition program for women, infants, and children. It's a federal program administered by USDA, FNS, or Food and Nutrition Services, that's been around since 1974. We celebrated our 50-year birthday last year. And the mission of WIC is to safeguard the health of low-income women, infants, and children up to the age of 5. Next slide. In Iowa, we have 15 local agencies. I saw a picture of the map earlier on somebody's presentation as well. So we serve participants in counties with other programs like the maternal health, oral health, child health programs. So that's why these CSAs were developed. So we have WIC clinics in all 99 counties with a statewide caseload recently of about 62,000. So it kind of goes up and down, but more recently, about 62,000. Next slide. The individuals that are qualified or eligible to receive WIC are pregnant, breastfeeding up to 12 months, postpartum women not breastfeeding up to 6 months, infants, and children up to age 5. I want to stress here kind of a call to action or a mini call to action. Many women report to us they don't realize they can be on WIC during their pregnancy. So if you're a partner with WIC or your program could just share about the WIC program as a resource for pregnant clients or patients. We have a lot of people that report not knowing about WIC during pregnancy, so it's a great resource at that time to get them started. Next slide. There are special criteria that must be met to participate in WIC, so they have to be one of those categories just mentioned. They have to reside in Iowa, they have to meet income guidelines, and then they need to be determined to be at nutritional risk. So they see us at WIC for an appointment every 3 months after they've had that initial certification, and those appointments can be in person, by phone, by our nutrition modules, lots of options for that. Next slide. So a little bit about the benefits. Next slide. So the 3 main benefits that WIC is known for that WIC provides are the supplemental food package, nutrition education, which includes breastfeeding, promotion, and support, my baby that I love talking about, referrals to healthcare and other services as well. So WIC focuses on bettering maternal, child, and infant health by providing these benefits and services. So there's some facts here that I always love to share, especially with audiences like this one. Pregnant women participating in WIC receive prenatal care earlier. They have longer pregnancies closer to their due dates. They have appropriate or more appropriate weight gain. They have improved dietary intake during pregnancy and in the postpartum period. WIC also reduces fetal deaths and infant mortality, decreases low birth weight rates, improves the growth of at-risk infants and children, and decreases the incidence of iron deficiency anemia, and significantly improves child's diet. So lastly, WIC has been proven to be cost effective. So there's been, I think, over 70 studies on WIC showing how it is an evidence-based effective program. So that supplemental food package I wanted to talk about, it's considered supplemental, so not intended to be the main source of food or nutrition for the participant or their family. Each food package is designed for a specific participant category. And the items listed on the screen here are foods with nutrients that are generally lacking in the diets of WIC participants. So new in 2025, the WIC food package was revised and updated, and we've started offering different food options and quantities to families. So you might hear from some of your clients about some changes at WIC. So at a high level, because we could go on about this for a day probably, the changes align with the latest nutrition science and provide a more variety, choice, and flexibility for participants, as well as are focusing to support for breastfeeding families to meet their goals. So if you have any questions about the new food package and the changes, don't hesitate to reach out about that. WIC, one of the most important pieces, just besides the foods that WIC provides, is the nutrition education for all participants or to their parent or guardian if they're a child or baby. And the education is offered by usually dietitians or nurses. We have some roles called nutrition educators or doing some work to train paraprofessionals, as well as we've seen a shortage in the dietitian pool, not just in Iowa, but nationally. So this nutrition education can be provided face-to-face, options for on the phone. WICHealth.org is our online module system for education. And then some of our agencies host facilitated discussions, classes, support groups, those types of things. Next slide, please. For this population, I always stress that breastfeeding promotion and support is a major focus of the WIC program due to the many benefits for both mom and baby. And ways WIC supports breastfeeding are by offering evidence-based breastfeeding education and resources, one-on-one breastfeeding assistance, assessment, weight checks. Those benefits are provided by qualified breastfeeding support professionals. Our WIC clinics have IBCLCs, CLSs, CLCs, a whole alphabet soup of different lactation credentials. We have access to the breastfeeding peer counseling program, with many of which are bilingual staff, and provide breast pumps, breastfeeding accessories, and then again, like I mentioned before, those breastfeeding classes and support groups. So next slide too, sorry. And I just wanted to talk about some fun projects we've had going on nationally, and in Iowa, we've had a major focus on modernizing the program to meet the needs of the participants we serve and kind of keep up. So in Iowa, we've first put a strong emphasis on the ability to offer remote services to continue to grow flexible options for WIC services. We really learned a lot of lessons during COVID. And so nationally, there's been a big push for this tele-WIC option, which just creates more flexibility for families that have barriers getting into clinics, or, in January when we have weather and we don't want people out on the roads with their little ones. So we continue to also promote and update our online nutrition education module system, that WICHealth.org. It's a system where participants can access modules to replace a nutrition education appointment, or access it if they are interested in another topic as well, at their convenience. So that's the major importance with that one. It's at their convenience from their home or wherever they are. And the system provides these educational modules, but also has other resources, handouts, recipes, stuff like that. We have an app we use. Sorry, still the same slide. This slide is longer. We have an app we use so people can scan foods at the store to see if their food they're looking for is WIC, or they're looking at is WIC eligible. Our approved food flyers on that app. They can see what benefits they have remaining. They can find stores that accept EWIC. And then we've been doing this online ordering, no longer a pilot, it's expanded to be statewide with Hy-Vee aisles online. So WIC participants can order their groceries online, just like you would be able to do any other groceries, and they can just drive through, pick up their groceries, and continue on their way. So we're hoping to expand the number of stores that are available with this option, but it's been a big convenience and success. So we're continuing to move forward there with other options. And then I wanted to mention this health information exchange for sharing participant data. So with WIC, we do heights, weights, hemoglobins at their certification appointments. And we've been working on a project called the Health Information Exchange, where we can actually access some of those data points with certain providers to reduce barriers for gathering that data, especially in some of our telehealth type appointments. Lastly, just to keep up, we're modernizing our data system. So that's always a work in progress. And co-location of services, I wanted to mention. So many of our local agencies have these creative WIC coordinators who are partnering with or hosting clinics in collaboration with other programs like maternal or child health, I Smile, food pantries, medical clinics, even in hospitals, at farmers markets, all sorts of different places when possible, which makes accessing critical services easier in a one-stop shop type model to meet families where they are. So we've seen a lot of really innovative ideas from local agencies. Just excited to continue to expand opportunities to serve families. In fact, one of our WIC programs here in Polk County just released this year a WIC mobile. So they've got a van that they're going to be able to run around their service area with to serve families that way. So I just wanted to put some resources here on the screen for you. If you're interested in learning more about WIC, the website on the page where you can find more about the Iowa WIC program and then the WIC program at the national level. And I stuck the WIC breastfeeding support website on there too, which is a good one to share with your families. And lastly, my call to action is just, I wanted to leave you with an ask that if you don't know where your the WIC agency is that serves families in your area, please look on the site on the screen. Great if you do connect with them already, but if not, introduce yourself, reach out, describe what your program and services are, and find out if there's an opportunity to partner or set up a referral process between your two programs. So with that, I think I made it in my time frame. If not, hopefully it was close, and happy to take any questions.
Thank you so much. I would love for all the panelists to come back on video if they're still there. I think just to highlight all the amazing speakers and organizations that you are part of, that you shared today. I know 6 minutes was a hard thing to do, so I really appreciate it. I do want to open it up to at least one question from the audience, and I'll call on Kimberly to ask that, and anybody on the group can answer. So you can just unmute, raise your hand, whatever you want to do. We'll go ahead and do that, and then we'll turn it over to Dr. Radke to kind of wrap up for us. So go ahead, Kimberly.
Thanks, Megan. So I think it's clear from today's presentations that collaboration is really the key to improving outcomes for Iowa families. I would love for you to share one thing that we can all do, everyone here today, to help increase awareness about the resources that are available and help reach those families most at risk of experiencing adverse birth outcomes.
I think that's a relatively challenging but also easy question. Know what's available in your community and also understand that you don't have to have all the answers, right? We're all here doing amazing things, having really good outcomes and impacts in the community. And so reach out. If you are not the right person to guide a family, there are people who are, and reach out to those people. Don't feel like you have to figure it out yourself because there may be a better option. And the better option is not necessarily about you, it's about what's needed for the family.
I love what Brittany said too, be a bridge, not a hub. I love that. Anybody else?
I was just gonna say, Ebonie, you stole the answer I always give. Like, you know your resources and know when it's your expertise and when it's not, and connect them to where they need to go, because you're actually hindering the services more by not providing the connection.
And trust your gut. There's 200 plus, probably mostly women on this call. Whether it's your own health or when it's helping someone, don't think just because you don't have a lot of letters behind your name that you can't be helpful in either sharing your experience or realizing something's off and I need to help.
Exactly.
And I think just partner with the organizations that serve the same type of people, populations that you do, and figure out how you can work together. Lots of creative ideas have been going around, but just where can you co-locate? Where can you provide services to the same populations and make it work for the schedules of everybody to provide that kind of one-stop shop, like I mentioned during my piece.
Exactly. I think that's one of the things is like, where can we find all these resources? Like where can we easily access these things for people in Iowa and nationally? But I think this is a good start, and having all these connections. Does anyone want to say anything else before we kind of close and pass it over to Dr. Radke?
I have one other thing.
Yes.
This work that we do is so relational, right? So don't be afraid, even if we don't serve the same population. We do. because we're serving birthing individuals, right? And so don't be afraid to reach across the aisle and grab coffee or meet up and get to know the other organization, because that's where true partnership is in real relationship and not just knowing the resources. Actually know them, know the people there, be in relationship with them. And so when a client does come up or a participant comes, you already have that connection established. So don't wait to make those connections. Be proactive about it. We're all in the same work. It takes all of us.
That's awesome. Thank you so much, Audrey, for saying that. And I know we're not together, but we can all give a virtual round of applause for our amazing panelists. Thank you so much. We have about 15 minutes left, and I really want to give the floor to Dr. Radke to kind of close for us today and share a little bit more. But after she's done talking, I'll have a few final reminders for you, so don't just log off right away. But Dr. Radke, I think you should have the ability to share your screen. Thank you again to our amazing panelists. So you are up, Dr. Radke. There you go.
All right. Doing the Zoom check. Does this look normal, or do you guys see the notes screen that doesn't have any notes on it?
Nope, you're good. This is perfect.
Okay. Perfect. Well, thank you so much for one, inviting me to have the opportunity to close out the morning. And then also, I just really want to thank everybody who spoke. I think I'm familiar with almost all of your organizations, or I was previously, but it was just, I think, really powerful to hear people going one after another in this format, to just really recognize who all is here and is working hard in our little Iowa community. And then I was also impressed by the people who joined us today, that not everybody is from Iowa, and I just appreciate people joining. So I was asked to reflect on the morning, and as I was looking ahead of today at who we were going to be hearing from, it really resonated with me that this is, as has been said by some of the other speakers, really evident that everybody has a role in this, and everyone has an opportunity to help contribute in their own way through their own organization or their own experiences to improving maternal health outcomes. So I speak about maternal health outcomes a lot, largely to clinical and public health audiences, but I always like to, let's see if my slide's going to move. Yes, I always like to remind people, and I think we've kind of heard a bit about this today, that there's really a spectrum of outcomes, and very appropriately so, maternal deaths get a lot of attention. Nafla spoke about the Maternal Mortality Review Committee here in Iowa. I'm currently the chair of that committee, and I think that's a really important thing that we have and that the majority of other states have. But deaths are still really rare. And while we don't want any of them to happen, and we want to learn as much as we can from them, they're not the only outcome. And it's still a really small number of events. And so we can't know as much as we need to know from just looking at those. I think one of our speakers mentioned severe maternal morbidity, which is kind of an in-hospital measure of potentially near-death events, and that can be useful in healthcare spaces to understand other opportunities to improve care, because SMM has really similar drivers as death in many spaces, although I think that mental health is not well represented in SMM, or really not represented at all. And so we have work to do in the space of people who think about how to measure things at the population level, about how do we find that morbidity equivalent for mental health related deaths, so that we have a little bit more of that canary in the coal mine to understand what's driving things. But I also want to highlight that well, not only a few people, of course, die, and about 80 to 100 people for every one woman who dies, 80 to 100 will experience severe maternal morbidity, and those are obviously devastating outcomes. But there are a lot more people who experience some degree of a pregnancy or postpartum complication. And I think that there's a lot of work to be done in this space as well. I think every layer of this pyramid deserves attention. And I think a lot of the organizations that we heard from today are working maybe a little bit more in this space as well, thinking about people who have preterm birth or who suffer from a pregnancy-associated mental health condition or experience a pregnancy complication like preeclampsia that may have lifelong impacts but doesn't rise to the level of severe maternal morbidity. I think there's a lot that can be done. And I also wanted to reflect on a lot of health outcomes are dependent on so much more than medical care. And I don't say this to try to, like, I am in the medical community, of course. I'm an OBGYN. I don't think I said that at the beginning, but I'm an OBGYN. I practice at the University of Iowa as a laborist, meaning that I only take care of people during labor and delivery because I spend a lot of my time in the public and population health space. But we know in general for all health outcomes across the spectrum of life, so not just talking about pregnancy-related outcomes, we know that kind of how healthy someone is relates a lot more to social factors around them, the community that they live in, the family that and friends that they have, where they work, where they grew up, their education has a much greater impact than the medical care that they receive. And I think this is particularly true in the US, where our medical system is really not as well designed to provide preventative healthcare services. We provide really, really good sick care in the United States and perhaps lead the world in disease treatment, but are really behind many other countries in thinking about how do we design communities and social structures in our society to help people be healthy and prevent issues before they arise. And so I think about that a lot in the maternal health space, and I don't know if 80/20 is correct. I certainly wouldn't attribute that for maternal mortality, but I think that there's more role that medical care has. But I do think that we can't do everything within any one system, as has been said, and so we really need to partner together. In public health, we think a lot about how much social factors and socioeconomic factors drive health. And so this is called the health impact pyramid. If you work in a public health space, you're probably familiar with this. But I think it's a really useful visual to understand that when we think about increasing the population impact of an intervention or a program, what's going to really have the highest impact are things that really address making it easier for people to be healthy to begin with, making it easier for them to make healthy decisions, long-lasting protective interventions in the healthcare space. Vaccines are a really good example here. But unfortunately, we invest a lot, particularly in healthcare in the top of the pyramid, clinical interventions that are really secondary and tertiary disease prevention, and then a lot of focus on patient education. And not to say that that isn't important, but recognizing that you can't educate people out of, conditions and situations that make it very hard for them to be healthy. And this is really putting a lot of onus at the top of the pyramid on individuals versus at the bottom on making communities healthier and making it easier for people to just be healthy from the beginning. And again, I think a lot of what we heard this morning is people thinking a little lower down on the pyramid. Another model that we use a lot in public health that I think was the first thing that came to my mind when I thought about reflecting on the diversity of organizations that we were going to hear from this morning is the socioecological model. And in a way, it's sort of the pyramid presented in a different way. And in my visual, it's sort of upside down here now. But really thinking that at the center is the individual who may experience an adverse pregnancy outcome. And what can we do at the individual level is often direct medical care and things like that, and helping people to make the best choices and access the care they need. But then thinking about how much more influence there is beyond the individual level. So the interpersonal level is thinking about who are those people that are around somebody during this time in their life, their friends, their family, their immediate social network. what institutions are they engaging in? And so that would be like, what is their place of work? And what sort of policies may apply to them there? Where do they get their health insurance and healthcare from? And then the next level is the community. Where do they live and work? What's available? What resources are in their community that they can access? And then at the highest level is thinking about the policies that oversee the area that they live. And so again, we can make really big impacts when we think at some of these outer rings. And really every ring of this is really important. And I think I didn't add it all in, but you easily could have kind of like added a logo from each of the organizations that we hear from and think about what level of this model are they working on. And we have people working on all levels, which is really important. Because as has been said, everybody has a role. I think initially, maybe 10 years ago or so, 20 years ago, as there was really starting to be rising awareness in the public about maternal mortality and severe maternal morbidity, the initial conversation, and this may just be my perception of it because of what I do for work, but it felt a lot like the whole conversation was like, what are OBGYNs doing wrong and how are we failing women? And I think there are many examples, and the IPQCC does a lot of work to improve the quality of care that's delivered in healthcare systems. But I think events like today really bring us remind everybody that everyone has a role, and it's not just in healthcare, and it's also not just in public health, and it's not just in communities. It's really, we will improve. I don't want to say solve because I think there will always be work to do, but we will only improve when everybody is working together and everybody recognizes that they have a piece of this puzzle to contribute, and that everybody's piece is super important. And I love the idea of getting everybody together so people are hearing about each other, because I think that we are really, really siloed in our care delivery of our different programs. And oftentimes, a patient might be engaging with the healthcare system and have a need that doesn't align to something that the healthcare system can deliver. And if people don't know what's available in their community or how to help somebody access resources, we do nothing, or the best we do is like hand somebody a business card for an organization and we don't really know how to get to it and we don't know where it is or exactly what they do. And that really doesn't empower somebody to access those resources, nor does it really facilitate the ideal kind of warm handoff and connection that welcomes somebody into the services being provided. And so I think events like today are really important to get people to step out of the spaces that they, engage in daily, to think about who else is working alongside them in their community that they may not be talking to. Nafla mentioned the MMRC report, and I'm not going to read these because these are lengthy, but I pulled some of the top recommendations from the most recent report that are really targeted at the systems level, and want to highlight just that we really recognized in a lot of deaths there was a tremendous opportunity to improve care coordination and patient navigation, essentially that we witnessed people not accessing resources that we knew were available in their community. A lot of instances where we felt like there needed to be policy level changes to allow people paid leave to attend healthcare appointments and then to have adequate parental leave. And then a big need for substance use disorder treatment programs in our state that are organized in areas with need. And then at the community level, we had observed opportunities to reduce access or immediate access to firearms in the community, particularly in people who are experiencing mental health disease. Again, care coordination and really wanting to see a system where there is no wrong door to enter for care, that if any place that somebody who has a need enters a system, that they can then get connected to everything they need. And so that might mean that their front door to the system is they walk into an emergency department, or maybe they walk into a public health clinic, or maybe they walk into a food pantry, and then making sure that we have a network that then easily connects that person to where else they need to be. And again, another call out for a need for substance use disorder treatment programs in our state. If anybody is interested in reading the full, although I will say abridged version of the of the report on 2019 to 2021 deaths. You can scan this QR code. And unless it has broken since I put it in a previous presentation that I used this slide in, it should lead you through to access it. If you Google it, you'll also find it as well. And I will note that this is the abridged version. We generate a lot of recommendations when we review deaths, many recommendations for every case. And so if you are interested in reading all of the recommendations, because we did not publish them all in this abridged report because it would have been very long, you can reach out to NAFLA and those should be able to be made available to you. I will reiterate what Amanda said when she was speaking about our organization, the Iowa Perinatal Quality Care Collaborative, that we are about to launch enrollment for hospitals and clinics in our broad mental health initiative that is going to focus on perinatal mood disorders, intimate partner violence, social determinants of health, and substance use disorders. And it is going to be big, and it will take us 2 years to get through it, but we are really excited. This is the framework in one image that we are going to build off of, which is improving recognition of people who have needs, improving empathetic and respectful responses when people do screen positive, and then having a warm and welcoming handoff to community resources for people who need them. Many of you will be tapped upon to come in as guest speakers to talk about your organization and what you do for people here in Iowa. And then my last plug, all of the morning speakers were asked to have a call to action. And so my call to action is I would just invite all of you, if you are not engaged with the Iowa Perinatal Quality Care Collaborative, which is Iowa's perinatal collaborative, to please reach out. We have a stakeholder advisory board. We meet about quarterly, a little bit less than that this year because we are federally funded and we've had less contact with our it's been a disruptive year for people with federal funding, as I'm sure many of you know. So we've had a few fewer meetings this year as we've just sort of navigated some changes to make sure we comply with executive orders. But we convene the stakeholder board and really lean on them to give us information about what is a priority, where should we be focusing our efforts within the space that we can influence, which is largely how healthcare is delivered to people who are pregnant and parenting. We do have a neonatal arm, and we would love to invite more community members and really anybody who has interest to join our advisory board and potentially contribute to some strategic planning on some of our activities and strategies. So our coordinator is Nicole Anderson. You can reach out to her to get added to that listserv. And that's all I had. And it looks like I went right up to 11:29. So thank you for listening to me recap and for hosting this event today.
Thank you so much, Dr. Radke. That was just a fantastic overview of everything we captured. And one of my colleagues was messaging and she's like, we need a word cloud of all the phrases that we said, collaboration, bridges, Dr. Radke fan club checking in. Exactly. That's what I agree. I think this just shines a light on all the ways we can connect. And I hope that you all really take heed to the fact that we're asking for this collaboration. Like she wants you to email Nicole and join this group. I mean, this is so important. We do truly play a role together. So I just want to thank you all for being here today, for sharing your passion and your drive and your expertise and everything that you do. Thank you so much, Dr. Radke, for really doing that and shining a light and guidance on what's next for everybody. Thank you to all the speakers today. You shared so much valuable information and knowledge. I know it was a lot of information. It seemed like a large amount of time, but really it goes fast, right? So day 2 will follow a similar format. We don't have Ignite sessions tomorrow. It is a full day though. It's 8:30. I'll start around 8:15 with some of that music and stuff, but we will start at 8:30 and most of the day is filled with panels. So it will be a little bit different than like an Ignite session, but a lot of different panels. The same Zoom link that you joined today is what you'll want to use tomorrow. There's no need to log in again or find anything. Just keep this link handy. It should work. We can't wait to continue these important conversations and learning with you all tomorrow. Again, thank you so much for joining us virtually. Once again, reminder, you will get an email with the recording information, the slides, any handouts from providers and speakers today. And again, the continuing medical education will come from Des Moines University within 6 to 8 weeks after the event. Please complete the evaluation. We want to extend our heartfelt gratitude again to our presenting sponsor, WellPoint, for your incredible support and commitment, as well as our additional speaker or sponsors that really helped make these 2 days possible. And so with that, I will let you all go. 2 minutes past. I can't believe it with how many speakers we had. So I think that's pretty dang good. I hope to see you all tomorrow and have a fantastic afternoon.